Good morning. I'd like to welcome everyone this morning to the Committee on Oversight and Government Reform and to a hearing which is entitled America's Heroin and Opioid Abuse Epidemic. I'd like to welcome our ranking member, Mr. Cummings, and all the members and our witnesses this morning to this hearing, and call the hearing to order. Without objection, the chair is authorized to declare recess at any time. The order of business this morning will be as follows. We'll begin the hearing with opening statements from myself, the ranking member. Other members are welcome to submit opening statements. And with Mr. Cummings' support, we will leave the record open for how many days?
5 days.
Five days, legislative days, for additional comments or statements. Without objection, so ordered. And when we complete the opening statements, we'll turn to our panel of witnesses. We have 5 distinguished witnesses today, 3 at the federal level, 1 at the state, 1 at the local level for our hearing. We'll swear those witnesses in, and then we will hear their testimony, and then we'll proceed with questions. So that will be the order of business that will follow. So again, welcome, and I'll start with my opening statement. Unfortunately, the United States is experiencing a historic epidemic of drug overdose deaths. Today, drug overdoses are the leading cause of accidental death in the United States. In 2014, I don't have the 2015 figures yet, but in 2014, there are, listen to this, 47,055 deaths caused by drug overdose death. That means if this hearing lasts for 2 hours, 10 people will die in the next 2 hours in the United States from drug overdose death. More Americans, and this is the little chart showing you the increase since 1999. I remember I chaired Criminal Justice Drug Policy Oversight Subcommittee from 98 to 99, and we thought we had an epidemic back in 99 with 16,000. And I can show you some of the headlines from my local newspapers where we had people dying many people dying over a weekend. Unfortunately, that's what we're seeing again in my community and across the United States. Unfortunately, more Americans have died from drug-related overdoses in 1 year than all that were killed in the lengthy Korean War. If the current trend continues, the annual death rate could climb beyond those killed in Vietnam over that multi-year struggle in 1 year. The graph from the Washington Post illustrates the disturbing rise in drug overdoses between 1999 and 2014. Now, of the 47,000, more than 10,000 Americans died of heroin-related overdoses. Heroin use is increasing at a faster rate. You want to talk about a war on women and a war on our young people. The heroin deaths are killing our women twice the rate of men and 109% more with our youth. Unfortunately, we've seen, according to the Centers for Disease Control and Prevention, that again with heroin use among deaths among our youth between 18 and 25 in the past decade have soared and again lead the statistics, the deadly statistics. Across all demographics, the rate of heroin-related overdose deaths has increased 286%. While the exact cause of this epidemic is up for debate, Many experts believe the use of other drugs is also a driving factor. Addiction to other drugs, such as prescription painkillers and marijuana, potentially open the door to an epidemic now destroying families and communities. Those addicted to other drugs turn to heroin to get a similar high because it's cheaper and more readily available. Mexican drug cartels have established heroin trafficking routes here in the United States and coming across our borders. Now we see increased supplies in recent years. Had a chance to talk with my police chiefs and law enforcement folks in the district, our HIDA folks, our DEA folks, and we're seeing an incredible supply, and we'll have some questions about where that is specifically coming from. We know a lot of it's coming across the Mexican border. The impact, unfortunately, is felt in communities across the nation. Just a few weeks ago, I met with again, all of the local officials and we have one of my local officials who we'll hear from in a few minutes, Teresa Jacobs, our county mayor in Orange County, who's been forced to deal with a heroin epidemic in Central Florida and her county. In Orange County alone, and you'll hear more about this, we had 475 related heroin bookings in 2013. By the end of 2015, last year, we had 840. The majority of those arrested were between the age of 18 and 44. The Obama administration, unfortunately, I believe, has been sending mixed signals about the use of substances such as marijuana, which is one of the gateway drugs. Talk to anyone who's in counseling, treatment, rehabilitation, and you'll find out that marijuana is a gateway drug, and many of the heroin users start there and work their way up the chain of deadly drugs. According to the National Institute on Drug Abuse, now listen to this, more high school seniors are now using marijuana than cigarettes. A policy that has been adopted, unfortunately, has consequences. The Just Say No drug policy, which was championed by the late First Lady Nancy Reagan, has turned into a Just Say Okay policy, and now we're seeing the consequences. While improving treatment is a key, enforcement is and must remain an essential part of combating heroin epidemic. When I talked to the police chief and I saw the numbers in our locale, I said, well, it looks like you've been able to keep the lid on some of this, although it is now at epidemic proportions. And they told me, Mr. Micah, he said, this is only because we have now antidotes that can bring these people back. The only reason we aren't seeing double or triple the deaths is because our law enforcement and our first responders can bring these people back if they can get to them in time. Not only illegal immigrants are flowing over the Mexican border, but also illegal drugs. We know that's the main source of the supply of heroin, cocaine, and and marijuana and a host of other deadly narcotics. Stopping deadly drugs from entering the United States is a federal responsibility, and we'll hear from some of those officials engaged in that war. New statistics show federal drug prosecutions, unfortunately, are down 6% in the last year, 2015. This comes after a 14% drop since the beginning of the Obama administration so-called Smart on Crime initiative. Our frontline law enforcement officers, if we're going to save more of these kids and others who are overdosing, they should be equipped with the resources to prevent and save them from overdose deaths, not just our emergency medical officers. The EMS people get there usually after the first responders, and it may be too late. So this is something else we've learned from our local task force and law enforcement officials. One of the police chiefs in my district informed me that just within the last month or so, we had one student who had to be revived from overdosing 3 times in 1 week. That's astounding. What's astounding is he's still alive and we were able to catch that. Speaker Ryan announced addressing this current epidemic as a priority, and the Senate has acted on some legislation. I believe that this is absolutely critical, that this whole drug situation, including the heroin epidemic, become a priority for this Congress. I look forward to hearing from our witnesses today as we examine how to protect our communities from this fast-growing and skyrocketing national epidemic. I'm now pleased to yield to our ranking member, Mr. Cummings. And Mr. Cummings was my ranking member. We together led the effort from 98 to 2000. I remember going into Baltimore with him and conducting hearings there when the people were dying on the streets in huge numbers. But Mr. Cummings, we're back, unfortunately, backsliding, and here we are today. But he did a great job trying to save people in his community, and he's now the ranking member of our full committee. Mr. Cummings.
Thank you very much, Mr. Chairman. I want to thank you for holding a hearing on America's heroin and opioid epidemic. I want to take a moment before I start to extend our prayers to the people of Brussels, Belgium.
And I would join you, and I'd ask everyone for just a moment of silence if we could. Thank you, Mr. Cummings.
Thank you, Mr. Chairman. Today's hearing is about a national public health emergency, and we need to treat it like one. People are dying in Baltimore, Orlando, Salt Lake City, Manchester, and cities all across our nation. We can no longer ignore this public health emergency. Congress needs to put its money where its mouth is and actually help our states fund treatment programs to stop this epidemic in its tracks. Drug treatment facilities without adequate funding are like firemen trying to put out a raging inferno without enough water. Last week, Leader Pelosi sent a letter urging Speaker Ryan to schedule a vote on $600 million in emergency funding to help states address this epidemic before this recess week. Our colleague from Connecticut, Representative Courtney, has already introduced this bill in the House, and Senator Shaheen has been pressing this legislation in the Senate. Congress should not leave town until we take emergency action to increase funding to help states combat this epidemic. We must also fully fund President Obama's budget request for $1.1 billion in 2017. This crisis will not end in a day. It will take our sustained commitment, and every one of us owes it to our constituents to make that a priority. They want us to take action, and they want us to take action now. Let me tell you why federal funding is so important. In my hometown of Baltimore, I witnessed with my own eyes, in my own neighborhood, the destruction drug addiction inflicts on our communities. The first time I ever heard of a drug overdose death was 55 years ago from heroin. 55 years ago. I didn't understand it then. It's a young man in our neighborhood who we looked up to, who turned to heroin, named Bebe. And I can remember being so confused as to what this was all about. So I've seen vibrant neighborhoods and hardworking families and communities destroyed. In Baltimore, where many of the victims were poor and black, this went on for decades. Our nation treated this issue like a war rather than a public health emergency. We incarcerated generations rather than giving them the treatment they needed. Now, things are changing. Between 2006 and 2013, the number of first-time heroin users nearly doubled. About 90% of these first-time users were white. This epidemic has become a runaway train barreling through every family and every community in its path. It has no respect for barriers. It is now responsible for the deaths of 78 Americans every single day. Every single day. Why is this happening? In part, it is a result of doctors overprescribing pain medication and drug companies urging them on so that they can make massive profits. I'd like to enter into the record an op-ed by Emily Narciso that appeared in the Baltimore Sun on March 19th.
Without objection, so ordered.
I just want to read just a paragraph from this article. It says prescriptions of opioids have been traditionally limited to cancer, pain, and comfort measures. But in the mid-90s, drug companies began marketing these pills as a solution to a new plethora of ailments. In their efforts to expand the market, producers understated and willfully ignored the powerfully addictive properties of their drugs. The promotion of OxyContin by Purdue Pharma was the most aggressive marketing of a Schedule II drug ever undertaken by a pharmaceutical company. The Sackler family, which owns Stamford, Connecticut-based Purdue Pharma, achieved a place on Forbes' 2015 list of America's wealthiest families. The Sacklers, the richest newcomers to the list, are worth an estimated $14 billion. $14 billion. Now, going on, so as she explains, the United States has only a 5% in this article. We have 5% of the world's population, but we consume 80% of the world's painkillers. Tweet that. 5%, ladies and gentlemen, of the world's population, but 80% of the painkillers we consume. So yes, I believe it was unconscionable that our nation ignored these issues for decades. But now Republicans and Democrats are starting to work together. And I thank God that this day has finally come and the stars are starting to align for meaningful change. We now have people like Orrin Hatch, Chris Christie, Rob Portman, Kelly Ayotte, and Mike Pence realizing the gravity of this crisis and supporting more funding to help our cities and states. They're beginning to realize that this is not an urban issue, a rural issue, a black issue, a Hispanic issue, or a white issue. This is an American issue that affects your sisters, your brothers, your sons, and your daughters. There's something else we must do. We can no longer allow drug companies to keep ripping off taxpayers for life-saving medications. The chairman mentioned just a moment ago the drug naloxone and its life-saving effects. Cities all around the country have recognized the need to equip their first responders, police officers, and public health officials with naloxone, a drug that can reverse opioid overdoses in a matter of minutes. But their efforts have been directly undermined by corporate greed. As more first responders began using this drug, the company that makes it, Amphastar, began to increase its prices by staggering amounts. In May 2014, a 10-dose pack cost the Baltimore City Health Department roughly $190. Guess what? Today, it costs more than $400 for a life-saving drug. Despite repeated efforts by my home state of Maryland, and this company continues to overcharge for this drug. The company also continues to obstruct congressional oversight by refusing to produce all of the documents I requested last May, about their massive price increases. Mr. Chairman, today's hearing is rightly focused on the heroin and opioid epidemic. But I hope the committee will turn next to my request for documents, as well as my request for a hearing with executives from Amphastar. With that, let me welcome our esteemed panel of witnesses today, and I thank you for being here. In particular, I'd like to welcome Dr. Leanna Nguyen, the Baltimore City Health Commissioner, who has done an outstanding job. She is a true national leader in developing and carrying out effective solutions to the opioid crisis. We're very fortunate to have her heading our health efforts in Baltimore, and we're very pleased to have her here today. And with that, Mr. Chairman, I yield back.
Thank you, Mr. Cummings, and we, again, will leave the record open for members who came in late for 5 legislative days if you'd like to submit them at this point in the record. We now want to again welcome our witnesses, and let me first introduce them, and then we'll swear you in. I'm pleased to welcome the Honorable Michael Botticelli, and he is the Director of Office of National Drug Control Policy at the White House. We have Mr. Lou Melioni, and he is the Deputy Assistant Administrator for Diversion Control at DEA, the Federal Drug Enforcement Administration at the Department of Justice. And then we have Ms. Kana Emomoto, and she is the Principal Deputy Administrator of Substance Abuse and Mental Health Services Administration at the U.S. Department of Health and Human Services. And then we have Ms. Leanna Nguyen, and she is the Health Commissioner for Baltimore City Health Department. And then I'd like to also welcome my requested witness, the Honorable Teresa Jacobs, Mayor of Orange County, Florida. Some of you have been before us before, some of you haven't. We ask you that you limit your statements to approximately 5 minutes. You'll see a little monitor. You can also request to the chair additional statements or information be added to the record. So if you have a statement and you want to summarize it, you're welcome to do that. Since this is an Oversight and Investigations Panel of Congress, I'd like you to stand now and be sworn. Stand. Can you raise your right hand? Do you solemnly swear or affirm that the testimony you're about to give before this committee and Congress is the whole truth and nothing but the truth? All of the witnesses have answered in the affirmative, and we'll let the record reflect that. And then we'll first turn to our ONDCP representative, the Director of the Office of National Drug Control Policy from the White House, Mr. Botticelli. Welcome, and you're recognized.
Chairman Mica, Ranking Member Cummings, and members of the committee, thank you for the opportunity to appear here today to discuss the issues surrounding opioid drugs, including heroin and illicit fentanyl in the United States, as well as our federal response. During his State of the Union address, President Obama specifically mentioned addressing prescription drug and heroin use as a priority and an opportunity to work with Congress in a bipartisan manner on this issue that transcends party, income level, gender, race, and geography. The Office of National Drug Control Policy produces the National Drug Control Strategy, which is the administration's blueprint for reducing drug use and its consequences. Using our role as a coordinator of federal drug control agencies, in 2011, the administration released a plan to address the sharp rise in prescription opioid drug misuse that coincided with the surge in opioid drug prescribing at the beginning of this century. As this crisis has evolved, with an increase in heroin and fentanyl use and overdose deaths, the administration continues to put forward new initiatives to help deal with emerging issues. For example, in October, the administration announced a series of commitments it obtained from state, local, and private sector partners, as well as federal agencies aimed at addressing this epidemic. Opioids are having an unimaginable impact on public health and safety in communities across the United States. 57 people died each day from opioids in 2010, and by 2014, that figure was up to 78 people. The number of drug overdose deaths involving synthetic opioids other than methadone, a category including fentanyl, has more than doubled since 2012. These overdose rates are harrowing. However, we are making some progress. Past month, non-medical use of opioids by Americans 12 and older was significantly lower in 2014 than during its peak in 2009. And the number of people initiating the non-medical use of prescription pain relievers in the past year also decreased significantly during that time. Unfortunately, this progress has been counteracted by an increase in the availability and use of heroin. Heroin purity has been rising while prices have remained low. The heroin crisis is compounded by the reemergence of illicit fentanyl, a powerful synthetic opioid that is sometimes added to heroin to increase its potency or used unsuspectingly on its own. Since fentanyl is far more potent than heroin, its use increases risk for overdose death. While prescription opioid misuse far surpasses heroin use and the transition from non-medical prescription opioid use to heroin occurs at a very low rate, a recent review article concluded that this transition appears to be a part of the transition of addiction among those with frequent use or dependence, rather than a response to the reduction in availability of prescription medications, as some have speculated. Graduate medical education programs do not provide a comprehensive focus on the identification or treatment of opioid use disorders. A startling evaluation of healthcare claims data found that a majority of non-fatal opioid overdose victims were receiving an opioid from a prescriber, and 91% received an opioid prescription again from a prescriber following their overdose. In response, last year, President Obama issued a presidential memorandum requiring all federal agencies to provide training on the appropriate and effective prescribing of opioid medications to staff who prescribe controlled substances as part of their federal duties. Just last week, the Centers for Disease Control issued recommendations for primary care clinicians on the prescribing of opioids to treat chronic pain. The administration also obtained commitments by more than 40 provider groups that more than 500,000 healthcare providers will complete opioid prescriber training in the next 2 years. And the administration continues to work with Congress to make mandatory prescriber education part of their controlled substance licensure. The administration has also focused on several key areas to reduce and prevent opioid overdoses, including educating the public about overdose risks and interventions, increasing third-party and first responder access to the opioid overdose reversal medication naloxone, promoting Good Samaritan laws, and connecting overdose victims and persons with an opioid overdose to treatment. Yet there remains in this country a considerable gap that inhibits many victims of this epidemic from accessing the treatment they so desperately need. Therefore, the President's FY 2017 budget proposes $1 billion in new funding over 2 years to support cooperative agreements with states to expand access to medication-assisted treatment and to expand access to substance use treatment providers in areas across the country most in need of providers. And just a few days ago, HHS Secretary Burwell announced $94 million in Affordable Care Act funding to health centers to expand the delivery of substance use services, with a specific focus on medication-assisted treatment for opioid use disorders in underserved populations. While we appreciate Congress' support, the President's proposal underscores the need for additional funding to address this epidemic. To address the increase in heroin and illicit fentanyl use and availability, the National Drug Control Strategy focuses on identifying, disrupting, and dismantling criminal organizations trafficking opioid drugs, working with the international community to reduce the cultivation of poppy, and identifying labs creating synthetic opioids like fentanyl and its analogs. In addition, last year, ONDCP created the National Heroin Coordination Group, which is a multidisciplinary team of subject matter experts to lead federal efforts to reduce the supply of heroin and fentanyl in the United States. And we have also committed $2.5 million in high-intensity drug trafficking area programs to develop a heroin response strategy, providing law enforcement resources to address the heroin threat across 15 states and the District of Columbia. We have also been actively engaged with the government of Mexico on efforts to reduce the flow of heroin and fentanyl into the United States. Earlier this month, I met with Mexican Attorney General Gomez and other interagency representatives. We agreed to further collaboration on efforts to disrupt the production of heroin and fentanyl. This bilateral cooperation will be mutually beneficial to both our countries. Members of the committee, we remain committed to working with our federal, state, local, tribal, and private sector partners to reduce and prevent the health and safety consequences of non-medical prescription opioid, heroin, and illicit fentanyl use. Thank you very much.
Thank you, and we'll withhold questions till we've heard from everyone. Let me recognize Mr. Milione and welcome him, our DEA representative.
Thank you, Chairman Mica, Ranking Member Cummings, and distinguished members of the committee. DEA views the combined prescription opioid and heroin abuse epidemic as the #1 drug threat facing the country. I appreciate the opportunity to appear before you today and talk about what we at the DEA are doing to address that threat. Prescription opioids are walking users up to heroin's door, across that threshold, and into heroin's deadly embrace. Mexican cartels are entrenched in communities throughout our country, exploiting the prescription opioid abuse epidemic and flooding the country with high-purity, low-cost heroin. Those cartels are forming a toxic business relationship with violent distribution cells that are slinging that dope in our communities. What's the end result? In 1 year, almost 30,000 of our fellow Americans died from a prescription opioid or heroin overdose. As everyone has acknowledged, this is an unimaginable tragedy. DEA understands that we need a balanced, holistic approach to this epidemic. We stand with our interagency partners, including those represented here today, and embrace prevention, treatment, and education as critical to our success. However, enforcement must be a key component of our overall strategy. We need to investigate and bring to justice not those suffering from opioid use disorder, but those that are exploiting human frailty for profit. Our answer to dealing with this drug threat: attack supply, reduce demand, empower communities, DEA's 360 strategy. There are 3 prongs to the strategy: law enforcement, diversion control, and community outreach. My comments today focus primarily on the Office of Diversion Control's role in that strategy, but we'd be more than happy to follow up with details about Operation Rolling Thunder. Rolling Thunder is the heroin enforcement prong of the 360 strategy that is focused on the violent distribution cells that are pushing heroin in our communities and the Mexican cartels that are supplying the heroin that is killing so many Americans. With 1.6 million DEA registrants, DEA Diversion is uniquely positioned to assist in this fight with enforcement, education, and engagement. The vast majority of those 1.6 million registrants are law-abiding citizens. These are our practitioners, pharmacists, manufacturers, and distributors working in all our communities. We investigate the very small percentage of those that are operating outside the law, but yet inflict considerable harm on our country. For example, practitioners not prescribing for a legitimate medical purpose outside the usual course of professional practice. Pharmacists not performing their corresponding responsibility to ensure that the prescription is valid. Manufacturers and distributors not upholding their regulatory obligations to prevent diversion. How do we do that? With our tactical diversion squads, our diversion groups, and our great federal, state, and local counterparts. Our tactical diversion squads are specialized units made up of agents, diversion investigators, and intel analysts. We have 69 of them nationally. We're going to add 8, bringing our number up to 77 within the next 6 to 9 months. We're creating 2 mobile tactical diversion squads that can deploy where the need is, giving us a fluid enforcement capability. We have almost 700 skilled diversion investigators spread across this country in our diversion groups. Both the tactical diversion squads and the diversion groups work with the respective U.S. Attorney's Office to bring criminal and/or civil charges against those registrants that are operating outside the law. And where appropriate, They bring administrative actions, DEA's orders to show cause or immediate suspension orders, potentially revoking a registrant's DEA registration. As I said earlier, enforcement will be a key part of the overall strategy, but engaging with that large registrant community and educating them are just as critical. In the last 2 years, DEA Diversion has conducted more than 300 events, providing education and guidance to thousands of DEA registrants and industry leaders. Since 2011, with our great partners at the National Association of Boards of Pharmacy, we've conducted more than 64 pharmacy diversion awareness conferences in 29 states and have had the privilege of interacting with almost 10,000 pharmacy employees about the risks of diversion. Finally, we will continue engaging with our interagency partners on important initiatives, including expanding access to treatment, mandatory prescriber education, and the safe and responsible disposal of unwanted, unused prescription drugs. Early in February, a leading national chain pharmacy announced that they would place drug-back kiosks in 500 drugstores in 39 states and Washington, D.C. We see that as a very positive step in the right direction. We look forward to the day when those secure kiosks are so commonplace throughout our communities that people can dispose of their unwanted and unused or expired prescriptions frequently, safely, and conveniently. DEA will also continue our national take-back initiative with national events every approximately 6 months. During our September 2015 take-back, from 5,202 collection sites, we collected more than 370 tons of unwanted, unused prescription drugs. Our next national take-back event is April 30th, about 5 weeks from now. For almost 20 years, I've had the privilege of working with the brave men and women of the DEA, along with our federal, state, local, and foreign counterparts, investigating some of the most entrenched domestic and foreign criminal organizations threatening our country. This current drug threat, the subject of this hearing, is unlike anything I've ever seen. We at the DEA will do whatever it takes to fight this epidemic. We will attack supply, we will work to reduce demand, we will do our best to empower communities. I thank you for the opportunity to appear before you and look forward to answering any questions you have.
Thank you, and we'll get to questions after all of our witnesses. Let me recognize Ms. Inamoto, and she is the Deputy Administrator for Substance and Abuse Mental Health Services at the Department of Health and Human Services. Welcome, and you're recognized.
Thank you. Good morning, Acting Chairman Micah. Good morning, Ranking Member Cummings and members of the committee. My name is Con Inamoto, and I am SAMHSA's Principal Deputy Administrator, and I'm honored to have been delegated the duties and authorities of the SAMHSA Administrator by Secretary Burwell. Many thanks to all of you for your leadership to raise awareness and catalyze action on the nation's opioid crisis. As you have noted, this truly is a matter of life or death. I know prescription drugs, heroin, and illicit fentanyl have had devastating consequences in many of your districts. I know this because SAMHSA partners with leaders in your communities as they implement life-saving programs for individuals with or at risk for opioid use disorders. For example, the state of Maryland and the city of Baltimore are addressing high rates of opioid-related emergency room visits and utilizing peers to recruit patients into medication-assisted treatment. In Florida, SAMHSA's Prescription Drug Monitoring Program Interoperability Grant helped get critical data to the front lines of the fight to prevent prescription drug misuse. In Wyoming, we've seen fantastic progress as the state has implemented our strategic prevention framework using data and science to focus their efforts. And at the Odyssey House of Utah, with SAMHSA's help, it is increasing access to family-based, family-centered residential treatment for pregnant and parenting women with substance use disorders. Healthy babies are being born, and progress is being made. And while treatment admissions are increasing, overdose deaths have reached record numbers and not enough people are getting treatment. As a nation, we will not stem the rising tide of this public health crisis if only 2 out of 10 people with an opioid use disorder have access to the treatment they need. It wouldn't work for diabetes, it wouldn't work for HIV, and it will not work for addiction. We must join together to ensure that every person with an opioid use disorder who seeks treatment finds an open door. Toward this end, SAMHSA is proud to support the President's National Drug Control Strategy and Secretary Burwell's Opioid Initiative. In HHS, the Secretary's initiative focuses on 3 high-impact areas: changing prescribing behavior, increasing access to naloxone, and expanding the use of medication-assisted treatment and recovery. It is simple. To prevent prescription opioid misuse, we need to reduce the number of pills in people's medicine cabinets. SAMHSA will encourage the use of CDC's guidelines for prescribing opioids in order to chart a safer, more effective course to management of chronic pain. We know the vast majority of physicians and other prescribers are dedicated, well-trained professionals committed to their patients' good health. We must give them the tools they need to deliver high-quality, safe, and effective care. Since 2007, SAMHSA has provided continuing education to over 72,000 primary care physicians, dentists, and other healthcare professionals. We also reach local communities through drug-free community grants we administer together with ONDCP. These coalitions do yeoman's work to create environments that promote health and prevent drug use, including the misuse of prescription drugs, heroin, and illicit fentanyl. The second aim of the Secretary's initiative is increasing access to naloxone. As you have noted, naloxone can reverse a potentially fatal opioid overdose, but it only works if it's there when you need it. In SAMHSA's overdose prevention course for prescribers and pharmacists, one of the targeted strategies we promote is co-prescribing of naloxone with opioid analgesics, particularly for patients with high risk of overdose. We also let states know that they may use their SAMHSA block grant funds to purchase and disseminate naloxone, as well as for training and education on its use, and soon we'll be issuing a funding announcement for states to purchase naloxone and equip and train first responders. We appreciate Congress's strong support in this area. The third area of the Secretary's opioid initiative is expanding the use of medication-assisted treatment. Research tells us that medications, along with behavioral therapies and recovery supports, are important components of an evidence-based treatment plan. However, resources are limited and MAT remains significantly underutilized. As Director Botticelli noted, the President's FY17 budget requests $1 billion in new mandatory funding, which would focus on the continuum of prevention, treatment, and recovery services, with expanding the use of MAT, expanding the use of telehealth, and building the substance abuse treatment workforce. The initiative also includes, importantly, $30 million in new mandatory funding to evaluate the effectiveness of medication-assisted treatment programs under different real-world situations. On the discretionary side, SAMHSA proposes to maintain and grow investments made by Congress in 2015 and 2016. We're providing funding for 23 more states to expand treatment capacity for MAT, and we're preserving the behavioral health safety net by maintaining increases to the substance abuse prevention and treatment block grant. We've also worked with ONDCP and DOJ to clarify and enhance the connection between MAT and the criminal justice system. Drug courts are the most successful criminal justice response to addiction in our nation's history. This year, we will prioritize treatment that is less susceptible to abuse and diversion and expand our technical assistance to ensure that evidence-based practices are fully implemented. With all this new care, who is there to provide it? We must ensure that the substance use workforce is sufficient to meet growing demand. As such, we are requesting $10 million for a buprenorphine prescribing authority demonstration to test the safety and effectiveness of expanding buprenorphine prescribing to nurses and physician assistants. And the administration has requested $20 million for our colleagues at the Health Resources and Services Administration to grow the addictions workforce via the National Health Service Corps. Finally, SAMHSA is proposing a new regulation to increase the patient limit for physicians who have a waiver to prescribe buprenorphine. Members of the committee, thank you for convening this important hearing. I look forward to working with you to ensure that we are using our investments strategically, responsibly, and effectively to deliver the greatest possible impact for the American people.
Thank you, and now I'll recognize Dr. Wren, who's with the Baltimore Health Department, City Health Department. Welcome, and you're recognized.
Thank you very much, Chairman Micah, Ranking Member Cummings, and members of the committee. Thank you for calling this important hearing. I'm here as an emergency physician who has treated hundreds of patients with opioid addiction. I'm also here as the Health Commissioner of Baltimore, where I have declared the epidemic to be a public health emergency. Last year, Baltimore launched our three-pronged approach to fight this on the front lines. First, we have to save lives. That's why we're making the opioid antidote, naloxone, available to every single resident. In the ER, I have given naloxone to patients who are about to die and have watched them revive within seconds. Naloxone should be part of everyone's medicine cabinet. In 2015, we trained 8,000 people in the city on how to use it, including our police officers, who within 6 months have saved 21 citizens. In October, I issued a blanket prescription for naloxone to all 620,000 residents of Baltimore. But saving a life without connecting to treatment is just treading water. So our second approach is to increase on-demand addiction treatment. We believe that treating addiction as a crime is unscientific, inhumane, and ineffective. So our city's criminal justice and public health teams have partnered on drug treatment courts and on a pilot project where individuals caught with small amounts of drugs will be offered treatment instead of incarceration. The science is clear. Addiction recovery requires medication-assisted treatment, psychosocial support, and wraparound services. Yet nationwide, only 11% of patients with addiction get the treatment that they need. Imagine if only 1 in 10 cancer patients could get chemotherapy. Yet my patients come to the ER seeking addiction treatment, and I tell them that they must wait weeks or months. I've had patients overdose and die while they're waiting because we failed to get them help at the time that they asked. In Baltimore, we have started a 24/7 phone hotline that includes immediate access to an addiction counselor or social worker and a direct connection to make an appointment. Our phone line was started less than 6 months ago and already receives about 1,000 calls per week, including from police officers and family members asking for resources. We have ample evidence to show what works for treating addiction, but we're nowhere near getting everyone treated, and we're still very limited, especially when it comes to wraparound services. Take housing. Every year, we estimate that there are 18,000 turnaways for less than 100 recovery beds. Addiction treatment reduces crime and saves society money. We should invest in treating today rather than spending it on incarcerating tomorrow. Our third approach is to reduce addiction through educating the public and doctors. We launched a campaign to reduce stigma and encourage treatment at don'tdie.org. That also includes bus and billboard ads and targeted outreach in libraries, churches, and bars. Don't Die now has its first of its kind online naloxone training so that anyone who watches a short 10-minute video can print out my prescription to get naloxone. We're also targeting education to physicians. As the administrator said, doctors want to do the right thing. We have to give them the tools to do so. So I've sent best practice letters to every doctor in Baltimore to set prescribing guidelines and require the co-prescribing of naloxone with opioids. We're also alerting doctors to emerging trends. Nationwide, 1 in 3 fatal overdoses from opioids involves benzodiazepines like Valium and Xanax. Yet physicians routinely prescribe this dangerous combination together. Last month, I co-led a petition to the FDA with 40 other city and state health officials to call for a black box warning, which is the FDA's strongest risk communication on opioids and benzodiazepines. There's a lot that Baltimore has done to emerge as a model of overdose response and addiction recovery, but we need further support from Congress, including expanding funding for on-demand treatment and wraparound services like housing and peer recovery specialists, directly funding local jurisdictions, those of us on the front lines with highest need, removing regulatory barriers like the cap on buprenorphine and IMD exclusion, and regulating the escalating price of naloxone, and funding a national stigma reduction campaign. The epidemic of opioid addiction is a national public health emergency, and we know that addiction does not discriminate. We're all in this together. So I thank you for calling this hearing and look forward to answering your questions.
Thank you. Thank you. You're not allowed to, unfortunately, in these committee hearings to express your opinion or your approval or disapproval. I just have to let the public know that. Only your representatives can do that. Pleased now to welcome and recognize from my district, the mayor of Orange County, Florida, and some of you have asked where that is. Of course, it's Orlando is the principal city, and we have our mayor who started a heroin task force when we were hit with this epidemic. She's also accompanied by our, but they're not going to testify, George Rawls, raise your hand, who's our public health director, David Siegel, who lost a daughter and to a drug overdose and has turned that tragedy into a concerted public effort. And Karen Diebel Sessions is the former city commissioner from my fair city of Winter Park. So I welcome the guests accompanying our mayor and recognize Mayor Jacobs. Welcome.
Thank you, Mr. Chairman. Chairman Micah, Ranking Member Cummings, members of the committee, thank you for calling this hearing, and thank you for this opportunity to discuss a serious threat facing our cities and counties across the country. As Mayor of Orange County, Florida, allow me to share a few statistics. But first, Mr. Chairman, I'd like to ask that a statement from one of our constituents who you just introduced, Mr. David Siegel, be added to the record. Mr. Siegel is president of Victoria's Voice Foundation, and he's father of Victoria Siegel, who died last summer from a drug overdose at the young age of 18.
Without objection, so ordered.
Thank you. Many of you know Orange County as the home to Orlando and 12 other municipalities. We have a population of 1.2 million people. Last year, we broke a national record for tourism, entertaining more than 62 million visitors. But many of you probably don't know that last year we also lost 84 lives to heroin overdoses. And probably nobody will know that that was a 600% increase since 2011. 4 years ago, like so many other counties across the country, we were fighting pill mills. We worked hard. We adopted tough regulations at a local and state level. We provided resources to break opiate addiction, and we were pretty successful. Today, the front line has moved, but the battle is tougher than ever. Too many prescription drug abusers have found an inexpensive and often deadly alternative, heroin. Despite Central Florida's strong economy and our extraordinary quality of life, heroin has absolutely exploded. Last year, approximately 2,000 heroin users moved through our county jail. Many of these arrests, in fact, most of them, were not heroin possession, but they were other related offenses resulting from the debilitating effect that heroin use has on its users. Tragically, in 2015, we housed 100 expectant mothers addicted to opioids and heroin. Quite frankly, our county jail has become the treatment center of last resort for so many people. Yet too many people still don't realize the severe threat that heroin poses, not only to the lives of the addicts, but to the fabric of our community. For the good of our citizens and our whole community, we are fighting, and we are fighting hard. Last summer, I convened the Orange County Heroin Task Force, and I asked our Sheriff Demings to co-chair the effort. We have 22 high-ranking officials who served on the task force, from our chief judge to our state attorney, to medical professionals from all of our hospitals, to our superintendent of public schools, to representatives of our 3 colleges. I commend the effort of the Orange County Sheriff's Office and the Orlando Police Department, as well as our Metropolitan Bureau of Investigation, because since we formed this task force through collaboration and dedication, they have arrested more than 370 heroin-related incidents just in 6 months, 370. Last week, our task force concluded its efforts, and it made 37 recommendations, similar to the comments that you've heard from my colleagues here. We recommend bond increases for trafficking. We recommend media and social media campaigns warning about the deadly nature of heroin. Heroin is a serial killer in our community, and so few people recognize it for that. Coordinated efforts to avoid fatal overdoses by expanding access to naloxone. I commend the work of my colleague here, Dr. Wen. Congratulations. Naloxone, as you've heard, is a life-saving drug that is used in severe overdose situations. And also to look for new opportunities to fight addiction by coupling detox at our jail with addiction treatment programs using the drug Vivitrol. Vivitrol is a long-acting opioid antidote. In addition to moving forward with the implementation of these recommendations, we're working with our partners at the National Association of Counties, which has teamed up nationally with the National League of Cities. We're working with HIDA, and we're working with other organizations to implement the best practices. We know there is no single solution, but there are some universal effective approaches. Enforcement is absolutely critical to combating heroin use. In keeping what we learned with pill mills, we must be tireless in educating people that addiction is an illness. It's an illness that requires serious medical treatment. From law enforcement to families, the life-saving drug naloxone needs to be more accessible without a prescription and available at a reasonable cost. And one final point, I want you to know that in Orange County, through our collaborative effort, we're committed to doing everything we can with the resources that we have. Here's where we need your help. Help stop the influx of drugs across the border. We need you to continue to expand your efforts to stop these deadly drugs before they enter our communities. Local treatment and law enforcement will do their part, but the federal government must do everything possible to keep this plague from our shores and our communities. Help us treat more addicts. With a regional population of 2.5 million, we have only 26 beds for the uninsured, 26 beds, and yet 62% of the overdoses in our community are among the uninsured. And help us raise awareness so that more people would choose not to try this deadly drug in the first place. To end this crisis and to save lives, we all need to be engaged. I thank you for your attention to this critical issue. I thank you for your leadership, and I thank you for your service to our country.
I thank you, Mayor Jacobs, for participating today and all of our witnesses. And now we'll turn to questions. And I'll lead off. The scope of the problem that we are facing is I don't think people are comprehending this. From 16,000, when we chaired the Criminal Justice Drug Subcommittee, Policy Subcommittee, 16,000 to 47,000. We're approaching 50,000 in 1 year. Heroin is only, what, 20% of that, 10,000 deaths. When are the 15 figures coming out?
So we hope to have the 15 figures by the end of the year. But part of what we
By the end of the year. We can't get them till the end of the year.
Well, unfortunately, part of the issue is that these data get reported from county.
47,000 from 14, and I'm afraid it's going to be off the charts. That does not count, folks. That does not count. There are 35,000 automobile deaths in the United States. Half of those people have some kind of substance in their system when they're killing themselves. It used to be that teens, the biggest killer of teens was automobile accidents. Now it's drugs. Is that right?
That's
Yes.
correct.
It's killing our youth. We haven't even gotten into firearms. Firearms are the tool of the drug trade, and they have illegal weapons that they're using to commit robberies, mayhem. Again, it's an astounding number. We haven't killed as many in multiple-year wars as we're killing in 1 year. We will lose, guys, 500,000 people in a decade at the rate we're going or more. Every family's been affected by it, and now it's just a slaughter out of control. Now, we have lots of responsibility, and I'm all for treatment. Treatment is at the end of the process. They've already been addicted. We have got to stop this stuff at our borders. I sat with our police chief. I sat with our HIDA people. We put in place the HIDA. I had to do that by legislation a number of years ago because they play political games with even the creation of high-intensity drug traffic areas. But we did it years ago. And here we're back where we're far beyond where we ever were then. This is out of our newspaper from just a few days ago. 6 pounds of heroin at OIA. They're bringing these deadly substances, and it's not just heroin. Mexican, you talked about Mexican, and I said not just illegals are coming across the border, but they're coming across with drugs. Isn't that right, Mr. Maloney?
Yes, that's correct.
I sat with the HIDA folks and saw the pattern. These are cartels. They're organized. When I just heard, did you all see, what's his name, El Chapo? He said he came across the border. It was like a sieve. That was the major drug dealer, the most sought-after drug dealer, and he transits the border like it's some kind of a holiday visit to the United States. So somehow we've got to get a handle on this. I just looked up the prosecutions. The prosecutions, when we looked at the trafficking with illegal weapons, is down, and prosecution. I talked to some of my DEA folks. Now, they won't tell you this on the record, and they're not going to say this, but it's very hard to make cases on these guys. A lot of cases are dropped on the traffickers. These are dealers in death. And you're aware, sir, that we have, again, prosecution. You build the case, you give them to the district, and I'm going to demand a meeting with my U.S. attorney in the Central District and see why the prosecutions are down. But they're down. Did you know that?
I have seen that they're down. However, I've also seen that sentences have gone up, and I've seen that we're focused on the worst.
But they're telling me it's hard sometimes to make a case. These are murderers, and we can't stop them. They're bringing deadly substances in. And the trafficking pattern, too, trying to find out. Some is coming through the U.S. mail. I will say they told me the mail is starting to crack that down. It gets across the border, and then they transit it in the United States like they're sending some kind of a gift package. Is that correct, sir?
Many ways that it comes across.
Through packaging services, who also are intent on getting the package there on time. You got to get the deadly drugs there on time. So we've got to look at every avenue these guys are using. The border. I was in Mexico years ago. I don't know if you came with me on that trip, Mr. Cummings, but we warned them. It was now you do a DEA signature of, you can do that of heroin and cocaine, can't you?
Yes.
And you have looked at the stuff coming across. Where's it coming from?
Mexico.
Mexico. And 15 years ago, it was all Colombia, wasn't it?
It still comes from Colombia.
Yeah, but it was
Colombia.
primarily,
Right.
there was very little. There was some, I forget, was it black heroin or something coming out of Mexico. But Mexico were like the amateur hours in this game. Now they become the pros, and they're dumping this stuff in our communities. By the time we get to treatment, it's way too late. And it's kind of sad. I mean, I'm all for the naloxone and having that with our first responders where it should be. But I told you the story. One police chief told me 3 times in 1 week a student, they had to revive him. We're going to change out prescription drugs in the cabinet to naloxone so people are reviving their surviving kids and family. Where's the chart? Now, we have done a good job. Put the chart up on heroin versus... Okay, look at the opioid drugs at the top and heroin. We have actually brought that down a little bit. It went up. So we have been somewhat effective in cracking down on prescription drugs. But look what's happening with heroin. It's off the charts. It's being replaced by a cheaper and more available. They told me, sir, and you verify this from DEA, they said the price is down.
That's correct.
Yeah, it's down. When is the price down? When the supply is all over the place. So it's not just Baltimore, it's not Washington, D.C., it's not Orange County, it's New Hampshire, it's Kentucky, it's every state in the United States we're seeing this, aren't we, sir?
That's correct.
Yeah. So again, I get a little hot to trot over this, but you know, we deal with, our job is protecting the citizens of the United States. Primarily national defense. We saw what happened with a terrorist attack in Brussels. We are being attacked in our streets, in our schools, and our families with this. I mean, again, they killed today, what, 40 people? They killed 50,000 people in the latest statistics we have, which are more than a year old. And I know tough enforcement works. I work with Mayor Giuliani. New York, they stopped a lot of the crime, the drugs, with zero tolerance. Now we have just say maybe, and I just announced the new federal policy, just say okay instead of just say no. Doesn't it have to start, ONDC director, with families and communities?
I would agree that part of our strategy is to focus on primary prevention, that we know that by delaying when people use, particularly kids use alcohol, marijuana, or tobacco, we substantially increase the fact that they're going to have a life free of particularly drug.
And were you aware that high school seniors now abuse marijuana more than cigarettes?
Yes, I have.
Great commentary on our success in combating this with our youth. I'd like to yield now to Mr. Clay.
Thank you, Mr. Chair.
Okay.
And thank you and the ranking member for your comments on this, on the heroin and opioid epidemic. Let me start with Dr. Nguyen, and I want to commend you for the groundbreaking work that you're doing in Baltimore. And you're not just talking the talk when it comes to speaking out about ending the stigma related to addiction. You're walking the walk when it comes to expanding access to treatment for your residents. In your testimony, you discuss your efforts to provide treatment on demand on a 24/7 basis for Baltimore residents. I would imagine that ensuring someone can access treatment as soon as they present themselves as willing to do so is a powerful tool for making sure that they actually begin treatment, and that your approach will save hundreds of thousands of lives as a result. Today, one of the barriers to treatment is the Medicaid IMD exclusion, which prohibits Medicaid from paying for community-based, non-hospital inpatient residential treatment in a facility of 16 or more beds. Unfortunately, the IMD exclusion means that if you're on Medicaid, you're treated like a second-class citizen, unable to access what may be the appropriate care for your substance use disorder. For the residents you are responsible for in Baltimore, do you agree that they should have access to the medically appropriate care they need, whether or not they are on Medicaid?
Thank you, Congressman Clay. I absolutely agree, and I thank you for acknowledging that addiction is a disease. If a patient came to the hospital with a heart attack, we would never say, wait 3 weeks, and maybe if there's a bed available, we'll get you in then. The same thing should apply. The IMD exclusion is not based on evidence. We desperately need residential substance use disorder treatments, and removing the waiver on the federal level will allow us to increase the ability to treat all of our patients, regardless of their insurance status.
And that would put those patients on equal footing with everyone else so that we don't seem to be discriminating based on level of care.
Yes, and it would also increase more providers whom we desperately need at this time, where our treatment capacity is just 1 in 10 nationwide.
Yeah, and let me thank you for appearing here today. Every city and county, Mayor Jacobs, should have a health commissioner raising the alarm as forcefully and as effectively as Dr. Nguyen is, and hopefully Orange County has that. And Congress will finally heed the call and do something significant about the opioid epidemic, because it seems as though we as a country have come together and decided this is a national emergency. We should sit up and pay attention. So let me thank you too, Mayor Jacobs, for being here and for what you have done to raise the level of awareness in your community. Let me go to Ms. Inomoto. You testified about the work that SAMHSA does. Can you describe that work in additional detail? You testified of the $1 billion in new mandatory funding. SAMHSA proposes $920 million over 2 years to support cooperative agreements with states to expand access to treatment for opioid use disorders. Why is it important that SAMHSA receive these funds?
As you've so articulately stated, the need far exceeds the capacity of our treatment system today. And we believe that every person who has an opioid use disorder, who seeks treatment, just as Dr. Wen has done, 24-hour access to treatment, that should be the standard of care for everyone. With this President's proposal for $920 million to be infused across 2 years, we think that would supercharge the capacity of our states, of our communities with the greatest need, so that individuals who are seeking treatment would have an open door when they're ready to get that treatment. Because as we know, the window can be small for some people, and we need to take advantage of that opportunity when they come knocking.
Thank you so much for your response, and Mr. Chairman, I yield back.
Thank the gentleman. Let me recognize Mr. Turner from Ohio.
Mr. Chairman, thank you for holding this hearing. Mr. Cummings, thank you for your comments. This is certainly a scourge that is affecting everyone. In my community, I was touring a brand-new hospital, Soin Medical Hospital, and was taken back to a conference room to meet with the leadership of the brand-new hospital and ask them what is their most significant challenge, and they told me babies being born addicted to opiates. Now, a brand new hospital, out of all the federal regulations about all of the funding issues that they would have, you would not have thought that the biggest challenge a brand new hospital was having was babies addicted to opiates. Mr. Botticelli, thank you for all of your efforts. I appreciate your leadership. I think you're doing a great job, and appreciate your advice to Congress as to how we might be able to formulate our to-do list. Mayor, I'm a former mayor. Thank you. You live in your to-do list, and so thank you for your representation of your community. Ms. Inomoto, I'd like to put up a few slides that come from your fiscal year 2017 congressional budget justification. The first one being a quote that says that approximately 1 million Americans need but do not access treatment for an opiate abuse disorder. Again, these slides come from your fiscal year 2017 congressional budget justification. Ms. Inomoto, when we hold these hearings, we don't do them just merely for increased community awareness. We do them for a congressional to-do list, but also for an agency to-do list. So that's why I'm turning to your budget justification. We know 1 million Americans need but do not access treatment. The next slide. For example, more than 80% of state prisoners, 72% of federal prisoners, and 82% of jail inmates meet the criteria for having either a mental health or substance abuse issues. Staggering numbers. 80% state prisoners, 72% federal, 82% of jail inmates, mental or substance use issues. Next slide. Studies show, again, your budget justification, Ms. Inomoto, studies show that only 8.3% of individuals involved with criminal justice system who are in the need of substance use disorder treatment receive it as part of their justice system supervision. Ms. Inomoto, after I left that hospital, I then began the quest of trying to find out in my community, where are the resources? How can we find resources to provide treatment? In our criminal justice system in our community, I was introduced to people who are struggling to try to provide treatment to those who are incarcerated. And then I was introduced to a prohibition in your agency's funding that prevents it from being utilized for those people who are incarcerated. So in your very agency's documents, it indicates that the problem, we have, a self-sorting, right? We have people who present themselves in the criminal justice system with this problem. We have an understanding that without treatment, they will not be able to transition. And we will, as our chairman has said, once again be providing assistance to them in either an overdose situation or see them again in the criminal justice system. And yet in your funding, there is an exclusion that prevents communities from using dollars that they receive from you to actually address that for people who are incarcerated. And to Mr. Clay's comments, in Medicare, Medicaid, there are also similar exclusions that prevent people who are entitled to receive their treatment from receiving that treatment. I have a bill H.R. 4076 that would eliminate those restrictions, that would say, this is funding that's already there. It's not an increase of funding, although I am for increasing the funding, but this is funds that are already there that would just allow those people to receive it. Now, Ms. Inamoto, your agency, by rule, could eliminate that restriction. Why don't you?
You know, I think the issue that you've pointed out is clearly so important to communities all across the country. We know that people in our jails, in our prisons, are overrepresented with mental illnesses and substance use disorders, and getting them adequate care is absolutely important for this nation. At the same time, we strongly support approaches such as drug courts, diversion, early diversion, as well as reentry programs, and we've made significant investments to ensure that evidence-based—
Ms. Inamoto, I appreciate all that, but before we completely lose my time, could you please tell me why your agency won't waive the requirement and allow your funding to be able to be utilized for those who are incarcerated who need it most?
You know, I want to make sure that I get you an accurate answer to that, so happy to follow up further, either for the record or in person.
Excellent, and I do appreciate your hard work. I know you're trying to assist us also, and I would encourage members to please co-sponsor 4076 because it would help the agency have the momentum to waive the prohibition themselves. Thank you.
Thank you, Mr. Turner. Now recognize our ranking member, Mr. Cummings.
Thank you very much, Mr. Chairman. Dr. Way's hearing, we put into the record an op-ed from the Baltimore Sun. The effects of opioid overprescription are evident in the emergency room. It's entitled. The author explains that one reason we're now seeing such a huge increase in heroin overdoses is because legal prescription painkillers are being overprescribed. She says, and I quote, "Once a patient is hooked, he or she often turns to street drugs, which can be easier and less expensive to acquire." And I think you all, just about everybody else has said that this morning. Now, I want to be clear. I'm not trying to blame the doctors. They have a very difficult job. But Dr. Nguyen, do you agree that one reason we're seeing an uptick in heroin overdoses is because of the abuse of prescription opioids? Yes or no?
Yes.
The op-ed has a startling stat. It says, and I quote, "With only 5% of the world's population, we are consuming over 80% of the world's painkillers." The op-ed explains that drug companies are actively promoting this problem. It says, and I quote, "Prescriptions for opioids had been traditionally limited to cancer pain and comfort measures, but in the mid-90s, drug companies began marketing these pills as the solution to a new plethora of ailments. In their efforts to expand the market, producers understated and willfully ignored the powerfully and addictive properties of their drugs." End of quote. Now, that sounds like drug companies are almost like drug pushers. The op-ed cites several examples. For instance, it says this, and I quote, "The promotion of OxyContin by Purdue Pharma was the most aggressive marketing of a Schedule II drug ever undertaken by a pharmaceutical company." Dr. Nguyen, this is big business. How in the world do we combat this massive and aggressive effort by drug companies? I mean, and you know, when they're making billions. Go ahead, I'm listening.
Congressman Cummings, thank you for asking that question. And I appreciate your saying that doctors want to do the right thing. Mm-hmm. We want to do the right thing. And actually, when we talk to our communities, our youth also recognize, if we ask our youth in schools, is heroin good or bad? Mm-hmm. They're going to say that heroin is bad. But we have a culture of excess. We have, because of the aggressive marketing of drug companies, we have this expectation that there should be a pill prescribed for every pain. This is what we have to change. So we have to make sure that doctors get the resources, the tools that they need, including prescription drug monitoring programs, including guidelines that can help with safe prescribing, but also we need the resources when we're in the ER. We need the resources to connect our patients to treatment, because otherwise we also feel frustrated at knowing that our patients need care, but we can't deliver it to them.
Now, you talked about some guidance you sent out. Does that guidance also include using painkillers that are not so addictive or not addictive at all?
Yes, our guidelines include three things. The first is the necessity of co-prescribing naloxone with any opioids, because somebody could die from this, so they should get that as well. The second is to be careful about the opioid medications, knowing that they are not first-line medications. They should only be prescribed for severe pain. And the third is for the danger of benzodiazepines, which are also killing our residents.
So the op-ed goes on to explain that why drug companies are doing this, and there's no surprises, it's about profit. It says the Sackler family, which owns Purdue Pharma, achieved a place on the Forbes 2015 list of America's wealthiest families. The Sacklers, the richest newcomers to the list, are worth an estimated $14 billion. That's appalling. And I call that blood money, because people are dying big time. I want to go back to something, Mr. Onomoto, and maybe some of the others of you all can answer this. Yesterday, I was talking to a reporter, and he was saying that, Cummings, aren't you concerned that with even more money being requested for treatment and to deal with this problem, because there are so many more people getting into opioids and heroin, that money will be spread so thin that it will not have the kind of impact that you're hoping for? Mr. Monticelli?
Sure. So, to your point, I think we have to have a comprehensive response to this. And first and foremost, we need to rein in prescribing behavior in the United States. The Centers for Disease Control just put out recommendations last week that closely follow the guidance that Dr. Wen put out, because that is where we know is the significant driver to the problem. But we also know that despite all of our efforts, we still have too many people overdosing and dying, largely because they can't access treatment programs when they need treatment programs. And this is why that the President has put forward a significant proposal to expand treatment capacity in the United States. I hear this wherever I go. I just did a town hall forum in Toledo, Ohio, where the sheriff, I asked the sheriff what one single thing the federal government should be doing to address this opioid epidemic, and he didn't say we need more police officers. He said we need more treatment capacity because we're arresting too many people who haven't been able to access treatment. So we took a careful look at how many people need treatment and tried to adjust the proposal to really focus on making sure that as many people as possible had access to treatment when they needed it.
Just one more question. Dr. Wen, what happened? In other words, this was not a problem before, not as much of a problem, but then something happened. And can you tell me what happened? I mean, the numbers that the chairman cited, and I realize that people are moving from the opioids to the heroin, but what happened with regard to the opioids to get so many people on them and then for them to move to the heroin? Do you know?
My understanding is that there was aggressive marketing by drug companies so that the pain scale is something that's asked of every patient all the time in the course of their hospital stay. But the goal should not be getting to pain-free. The goal should be appropriate treatment. And yet this is the expectation that's placed on patients and on doctors. And so doctors are put in a hard place, too, of satisfying those requirements when all of that was done for drug companies' benefit.
Mm-hmm. So doctors have a tough time. So in other words, the patient keeps coming in, and the pain could be at a 2, being the mildest. Sure, I just used as much time as you had. Okay. The patient has a 2, and then he comes in, or she, and doesn't tell the truth, and says, I'm at a 9. Is that the kind of thing that happens?
That definitely happens, and then doctors feel that they have to get the patient's pain to 0, which includes overprescribing of narcotic painkillers in order to do so.
Wow. Ms. Monticelli, you seem like you wanted to say something.
No, I do agree that we've set up an expectation whereby opioids are the first-line defense around pain therapies. And I think what we're trying to do through the guidance and through Dr. Wen is, particularly for people with chronic pain, that opioids are not the first-line defense to really substantially reduce pain, that we have to focus on other, and the evidence seems to be pretty strong that people who are on chronic pain don't have significantly better functioning when they're on opioids, that we need to be thinking about things like exercise and diet and cognitive behavioral therapy and non-opioid-based therapies, particularly for people with chronic pain.
Last question. What do you, Mr. Turner asked a critical question, Ms. Enomoto, when he talked about, I guess he was talking about treatment in prison, is that right? And what stops you from providing treatment in prison? Is that what he was asking you?
Yes.
Yeah. What, there's a regulation that says you can't do that?
Yes, and I guess I want to check into that so I can make sure I get you a complete and accurate.
Yeah, please do. Please do. Because I'm wondering if it's something that Congress should be dealing with. I don't know whether that's in your control or our control. You follow me?
Yes.
But I'd appreciate an answer as soon as. Do you know, Mr. Botticelli?
I do not.
Okay, thank you.
I think Mr. Turner said it's in their control, and he has a bill to remedy that. Let me recognize Mr. Walker now. You're recognized, sir.
Thank you, Mr. Chairman. Appreciate this hearing. Appreciate the panel of witnesses being here today. Mr. Botticelli, you just talked about a few minutes earlier about treatment. I think you mentioned the sheriffs, if that's the one thing that federal government could do. Treatment is good and needs when we need more of it, but that's reactive after the problem already exists. Is that fair to say? So let's start from the very basis. I married into the medical community. My wife can write prescriptions as a family nurse practitioner, works in a level 1 trauma center. But one of the things I've seen as a minister for two decades is the introduction of marijuana. We've heard the statistic today already that more high school seniors now do weed instead of cigarettes. You recently discussed, I believe, the legalization of marijuana during a 60 Minutes profile, if I remember correctly. Do you believe that this could potentially lead to future drug use among the youth?
I do, and I think the evidence is pretty clear that when you're talking particularly about early drug use by youth, particularly alcohol, tobacco, and marijuana, that significantly increases the probability that people are going to have more significant problems later in life. In that episode, I talked about the fact that I and the federal government do not support the legalization of marijuana, because I do believe that when you look at the data in terms of the high levels of marijuana use that we have among youth in the country, and particularly when we have an industry that is quite honestly targeting our youth with things like funny cartoon characters and edibles, that we are in for more significant problems in the United States.
Part of our pop culture now.
I fear that we're replicating kind of what has happened in the past.
Do we have to worry that legalizing marijuana could lead to more drug use in the future for not just youth, but for people in general?
So when we have been tracking data for the past 40 years, and what it has shown is that when youth perceive using drugs, and particularly marijuana, as less risky, we often see an increase in drug use. And not only have we very high and historically high levels of marijuana use among youth, we are also seeing historically low levels of perception of risk of marijuana use among the youth in our country.
Just the question, I'd like to go down the panel really quick. I don't want to use all my time here. Does anybody disagree with the findings of Mr. Botticelli? Is just for record, does everybody agree that this marijuana usage is the beginning of what potentially could be a greater problem? So just for the record, I'm seeing everybody say yes except for Dr. Wen. Dr. Wen, you have a different opinion.
It is one contributor. Another contributor is our prescription drug crisis. 80% of people who start using heroin first start using prescription painkillers.
True, but most high school students are not going to the doctor and getting prescribed major types of pain relievers. Sometimes their first introduction is through purchasing of marijuana. Is that fair to say?
Yes, and also through misusing other prescription drugs.
Agree, and I want to, nice transition. I do want to come to that. I want to make sure that we're not painting the doctors as the bad guys here today. In counseling some of the people who have gone through some of this, as good as people they are, they have learned to become master manipulators. as far as going into the various doctor's offices, the emergency rooms. Mr. Cummings talked about the different pain levels, sometimes the threshold. Obviously, there's also scoring systems by customer satisfaction indexes that hospitals have to worry about. Dr. Nguyen, would you speak to that? Is that fair to say?
Most doctors are, by far, the majority of doctors are trying to do the right thing. And similarly, most patients are just trying to get the care that they want. Unfortunately, patients have the expectation that they have to be pain-free. But if I fall down and bruise my knee, I will have some pain. Getting opioids is not the right answer.
No, I agree, and I love what you said, a pill for every pain. We've got to go away from that culture, as you mentioned a little earlier. We have seen kind of a plateau, even though it's a large number of prescription pain. We've got to continue to do better, and I think it's people like in the community. I think of Richard and Jennifer Koffenberger in Central North Carolina. They had a son who had no drugs in his system except one thing. He had played a football game the night before. He had taken one prescription pain pill from his grandmother's medicine cabinet and methadone, and it killed him. Sad story, but they have taken that message throughout all their two educators or two teachers in a middle school in Burlington, North Carolina, and they've traveled different parts of the state to bring more awareness of what that can do. So I'm glad to see that that is plateaued, and we need to continue to stay on top of that. But I am overwhelmingly alarmed at the spike, and I'd like to see those 2015 numbers as soon as those are available of where we're going with this heroin epidemic. It is something that it's a problem for all of us, and we have to continue to do more. With that, I'll yield back the balance of my time. Thank you, Mr. Chairman.
Thank the gentleman. Let me recognize now the gentlelady from New York, Ms. Maloney.
I thank the chairman and ranking member and all of the panelists for focusing on this really crisis in healthcare in our country. And it's encouraging to hear your testimony and the efforts that are taking place in the city, state, and federal governments across our country. But we in Congress need to put money where our mouth is. And in the short term, I urge my colleagues to approve the $600 million in emergency funding, which the professionals are asking for to combat this epidemic. From what I'm hearing from Dr. Nguyen and others, is if we hit the treatment level when they're becoming addicted to the painkillers, if you hit it then it doesn't get to another level of the opium. So I think if we could fund it, that would be important. Now the Senate recently acted on this crisis. They passed the Comprehensive Addiction and Recovery Act of 2016 to help prevent and treat the opioid addiction, but it does not provide any funding. So what good is a program, Mayor Jacobs, that doesn't provide any funding? Does this program help people suffering in your city or your area?
Obviously, Congresswoman, funding is a necessary component of any program that we offer. If I could add just one thing, because we've talked a lot about treatment, and we have mentioned that that is on the tail end, that's reactive. This country came together, it galvanized around tobacco use, and it profoundly changed the way our youth looked at that. If this country would come together, if the Congress, if the state and local level, if we would come together around a campaign of awareness about how very serious heroin use is, opioid addictions, drug painkillers, all of those things, I think we could make a bigger impact at that level and stem the tide of this. But it will take
I think that's an
effort.
important point, but that whole tobacco effort, a lot of it stemmed access. It stemmed access to tobacco, and they made it more difficult to have access to tobacco. And I know the CDC just came out with some guidelines that basically says don't prescribe this so easily. You should have a higher threshold for it. As Dr. Nguyen said, when you fall down, you hurt yourself, you bruise yourself. You're not always completely, you're going to have pain sometime. We have to lower the expectation that no one can have any pain. If you have an operation, you're going to have pain. And it's certainly better to have pain than to become addicted to heroin or something worse. But maybe some concrete guidelines on access to it, that maybe the scientific community should define what pain level should have access to opioids, and that it should not be something that everyone should expect to be pain-free the whole time they're in a hospital. I mean, how would you react to that, Dr. Nguyen, to having guidelines that really stemmed access to very severe pain levels? Because what we're doing is, for someone to be comfortable for a week, we're turning them into addicts. I mean, this is a national health crisis. This has got to stop. And I would say to my colleagues on the other side of the aisle and on my side of the aisle, we shouldn't leave here until we vote that $600 million that's needed for the program. What good is a program if you don't fund it? It makes it sound like we're doing something when we're not really doing something. What they need is the treatment in the field. But I'd like to ask Dr. Nguyen, what do you think about reversing it? Not just education, but giving doctors help in knowing what threshold of pain would be necessary before this dangerous addictive drug is allowed.
Congresswoman Maloney, thank you for the excellent point. I agree with you that doctors need further guidance and tools in order to make the best decisions possible for their patients. And having guidance would also be useful because we don't want to punish doctors who are doing the right thing. And currently, when reimbursement is tied to getting the doctor or getting the patient to become pain-free, that becomes very difficult for the doctor to practice appropriately. But I also want to caution that there are appropriate uses for opioid medications, for cancer pain, for surgeries, so we don't want to eliminate that altogether. We just
Absolutely, but direct guidelines. Now, who would be the one to do that? The CDC? Have you looked at the guidelines that they just came forward with?
I have, and the CDC guidelines we agree with and actually hope that they would go further in requiring the co-prescribing of naloxone and also in helping us to put further warnings, including black box warnings on benzodiazepines and opioids, which are the FDA's highest risk recommendation to alert both patients and doctors.
Well, my time is up. Thank you.
Let me see. We have Mr. Buck of Colorado. You're recognized.
Thank you, Mr. Chairman. Mr. Milioni, I have a few questions for you. In 1970, Congress enacted the Poison Prevention Packaging Act to address aspirin overdose cases with children. And they, as part of that, a tamper-resistant container was developed for that purpose. We are now dealing with a situation where there are a huge number of young people who get these opioids from their parents' medicine cabinet. And I have been made aware of a product that I'm holding right here, which costs less than $1. It would increase the cost of the prescription less than $1, and it has a combination on it. It would require the parents to open that. If a child that didn't have the combination tried to get into something like this, there would be evidence of the parent that this was opened by someone that didn't have the combination. Has DEA looked into a packaging like this?
Congressman, obviously, as a father of three, we support anything that would serve that purpose, and we are aware of that company and that device.
You're probably aware the company comes from the great state of Colorado also.
I almost said that, but
okay,
yeah,
thank you.
So we are aware of it, and we were happy to listen to them about that technology. We would support that. We would support, obviously, the take-back kiosks to get drugs out of the medicine cabinet. That's a critical part of our overall strategy, but certainly any technology would prevent those dangerous drugs getting in the hands of children or anyone, we would support.
And what needs to be done? Do we need a law for that? Can you, by and I'm not a big proponent of administrative regulations, believe me, but can you, by regulation, require that dangerous drugs be dispensed in packaging like this?
We can require that they're disposed of. The regulations cover the disposal. As far as requiring how it's dispensed, I don't believe we can. I could certainly take that back and look at it. We've got to navigate somewhat carefully because these are, if this technology were made widely available, that would be great, but that would have to come from a private entity. It wouldn't be something we would be able to mandate necessarily.
So would you need an act of Congress to require, obviously, we're not going to name a company or a particular technology, but we would certainly require opioids to be dispensed in some kind of safe container. Would that be something that would help you in furthering this goal?
It would certainly help prevent it from getting in the hands of, like you say, children. It's something that we'd have to be happy to talk to you about or follow up if there was some pending legislation.
I would appreciate that very much. And Mr., I want to make sure I pronounce this correctly, Botticelli? Great. Wow. The federal government dispenses drugs through the VA and other agencies. Again, would it require an act of Congress, or could the federal government, for purposes of its dispensing drugs to federal employees or veterans, use packaging like this without a federal law from Congress?
I don't know that, and similarly, I think we'd have to go back and kind of look at what kind of authority we would have, or if the federal government needs additional authority to do that. You know, I will say that part of what we've been trying to do at the federal level is ensure that every federal prescriber at least has some level of mandatory education as it relates to those. But in terms of mandating a package, I don't know if either have the authority or we need additional authority to be able to do that. I could look into it.
If you could work with my office on that, I'd very much appreciate that, and look forward to working with you to try to develop this area. I thank the chairman, and I yield back.
Thank the gentleman. We'll recognize now Mr. Lynch, gentleman from Massachusetts.
Thank you, Mr. Chairman. I do want to associate myself with the words of the chairman and the ranking member earlier on this issue. And I think that there's much we can do on the treatment side, but up front, there's also the opportunity to reduce the number of people that require treatment. And I think we really have to double our efforts in that regard. Mike Botticelli, good to see you again. Mike, for those who don't know, headed up our efforts in Massachusetts for quite a few years, done great work. And I want to thank Mr. Milione for the DEA's help. My district has been overrun, so you've actually been kind enough to assign DEA officers and agents up in my area working with our local police, so we really appreciate the help there. Obviously, any individual state doesn't have impact on the border, but you do, and so that's been an enormous help for us in trying to interdict some of the heroin pipeline that's been coming up into the Boston area. I had the honor of co-founding the Cushing House in Boston for boys and girls. It's actually an adolescent treatment facility because our kids are coming in so young with addictions to both opioids and heroin. We've got basically 24 beds for boys, 20 for girls, but the problem is I got a line out the door, and it's happening over and over and over again. And I do want to say, just as a sidelight here, as I talk to our young people, and we've put thousands of kids through our home, and it's a long-term rehab facility. And while I don't know if marijuana is a gateway drug to heroin, but every single kid that I'm dealing with who's on opioids and on heroin started with marijuana. So there's a perfect match, 100%. Every kid I'm dealing with for heroin and for opioids, when I ask them, what did you start out with, they all say marijuana. So maybe there's susceptibility there or something, I'm not sure. It's not anecdotal, it's more than that. It's empirical over thousands of kids, but it certainly points in that direction. So I think it deserves a cautionary note in terms of some of this marijuana legalization. I think we're buying ourselves a huge problem. One thing I want to talk about and get your opinion, we haven't talked about the power of these opioids. And I'll give you a couple examples. Young woman in my district had a tooth problem. She had an extraction. They gave her a very large prescription of OxyContin. She consumed that, went back and complained falsely, she tells me now, of continued tooth pain, got another prescription, and actually went back in and complained that another tooth was hurting, which was not. So she's yanking teeth out of her head just so she could get prescriptions of OxyContin. That is unbelievable. And I talked to some of my docs in the Boston area, and they tell me that the chemical changes in the brain it overrides the OxyContin and hydrocodone actually overrides the endorphin creation in the brain. So it's more powerful than the endorphins that the brain can produce on its own. And so that's what, when they come off that, when they need that, that's why they're going for more OxyContin or heroin, because that's the only thing that can scratch that itch. So we gotta think about this. These drug companies are creating customers for life. Customers for life. When you say, and another young father in my district, shoulder pain, same deal, given too much OxyContin prescription, two or three scripts later, bam, now he's buying it on the street. And, you know, a good dad, good family, just totally fell into that trap. So we got to figure out, you know, I think it's a huge commercial advantage for some of these companies to produce a product that creates a customer for life. We got to think about what we're doing in that regard. You know, that's a huge commercial advantage. And I think that, you know, Governor Baker and the Mass legislature just come out and said, you know, if you're going to prescribe this stuff, you can only give so many pills. We're not going to let you refill them. So it's also part of our drug monitoring piece that we're doing along those lines as well. But is there anything on the front end, Mike, that we could be doing to stop the number of people? Because once they get in there, we're having terrible problem. We've got a lot of recidivism, a lot of relapse, a lot of money we're spending for rehab, and we need to do that. I'm not discounting that. But on the front end, to stop these kids from being trapped and other unsuspecting patients from being trapped into this cycle, is there anything else we can do up front to stop that from happening?
Sure. And I thank you for that question, because I think it's really important. And, you know, again, we talked, the CDC just released guidelines, but they're only guidelines. And, you know, I agree that I think the vast majority of physicians and dentists are well-meaning. And part of what Massachusetts has done, 16 other states, there's legislation in Congress now. We'd love to work with you on mandatory prescriber education, because we feel, again, this is not about bad docs. They've gotten a lot of misinformation, largely from drug companies, that these are not addictive medications and that we continue to hand them out. And I don't think, quite honestly, in the middle of an epidemic, it's unreasonable to ask a prescriber to take a minimal amount of education as it relates to safe and effective opioid prescribing. You know, if you look at the overdoses that we've seen here, there's a direct correlation between the amount of prescriptions that we are giving out and overdose deaths. And this has been going on for 10 years. Right. And I think the medical community has a role to play, and that's a good starting point.
What about liability? What about having joint and several liability for drug companies and the docs that push this stuff out there? Because these people are unsuspecting and they're getting addicted like that.
I agree, and there's been legal action against Purdue Pharmaceutical for precisely that reason. Right. That, you know, they have a role to play, not only in terms of making sure they're meeting the letter of the law about marketing, but also encouraging abuse-deterrent formulations is another particularly important area. You know, we do need to work with the DEA and others to go after outlying prescribers who are wantonly ignoring the law on this. But you're right, you know, we need prescriber education, good prescription drug monitoring programs, so physicians can identify people who might be going from doctor to doctor to do that. But you know, to your point, if we're really going to reduce the magnitude of the problem, we've got to scale back on the prescribing and identify people who are starting to develop problems.
I thank the gentleman, and I yield back.
Also, just, Mr. Lynch, I went into one of our drug programs in my community, talked to every kid I could in the, they're all youthful in the treatment program. Every kid told me the same thing. He started with marijuana, then they go on to all the rest of it. So we have a very serious situation in this country. Let me recognize Mr. Wahlberg is next, gentleman from Michigan.
Thank you, Mr. Chairman. And I apologize for being out, but Rosie the Riveter showed up at the Capitol, and I wanted to say hi to 4 of them from my district. Interesting issue, because it does affect all of us. And my district in southeast, south central Michigan has tremendous challenges there, and appreciate the efforts that all of you have shown toward this issue. Mr. Million, how long has the DEA been aware of the increased prevalence of fentanyl-laced drugs, and how are you responding to this problem specifically?
Thank you for the question. We've been aware of fentanyl going back a number of years, and we've seen its increasing use and seeing it flood the country. What are we doing? We're doing basically what we do with all our criminal investigations. We look to target the worst of the worst criminal trafficking organizations, identify them, infiltrate them, indict them, capture, convict them. And we're trying to educate, certainly, our state and locals about the risks associated with fentanyl. It's a multi-pronged approach. And it's definitely something we're concerned about. We're certainly concerned about the unsuspecting users that are being exposed to it when it's combined with heroin or when it's put into a replica, an exact replica of an opioid pill.
Are those the special enforcement challenges that you have, or are there others beyond that?
There's a whole panoply of different challenges, and that's certainly one of them. It also poses a risk to my law enforcement brothers and sisters that encounter increasingly fentanyl on an enforcement operation. And it, as you know, it can be inhaled, it can be absorbed through your skin with tragic consequences. So it certainly is a major problem for us, for users, for the country, and then also for law enforcement.
What has the DEA learned about the source of fentanyl when it appears in heroin?
Two primary sources. The majority of it's coming up from Mexico with precursors and actual fentanyl shipped from China, from Asia, into Mexico for production, and then across the southwest border all over the country, particularly up in the northeast, but also directly from China. So those are the two primary threats.
It's my understanding that Mexico has been a primary source. Is that true?
That is true.
How are you working to decrease this trafficking? Any additional efforts that you can talk about in regards to what's coming across the border?
We have a great relationship. It's one of our, if not our largest office in Mexico. We've got a great relationship with the counterparts. We continue to work with them on those trafficking organizations. The Sinaloa cartel is probably the most powerful cartel down there. It's got a tremendous distribution network spread across the country. They're capitalizing on the prescription opioid abuse epidemic. They're flooding the country with heroin, but they're also now flooding it with fentanyl. So we're just going to continue an aggressive approach from the law enforcement side and do what we do with our state and local counterparts every day.
Okay. Mr. Botticelli, what efforts is the U.S. engaging in to work with governments where heroin is produced to cut off the supply? And then secondly, does this involve identifying labs in countries like Mexico, which may be a trafficking bonanza of heroin and fentanyl in the United States, and what are the biggest barriers to stopping that?
You know, as we've looked at this issue, particularly heroin and fentanyl, you know, having an aggressive approach that reduces the supply is particularly important to do that. I actually was just in Mexico a few weeks ago, meeting with the Attorney General and high-level folks in the government, calling for enhanced action, particularly as it relates to heroin, looking at enhanced eradication efforts, looking at how we go after both heroin and fentanyl labs, and how we continue to support mutual collaboration on going after the organizations that deal with it. We've also been working with the DEA and our high-intensity drug trafficking areas domestically to look at reducing and going after those organizations that are trafficking heroin and fentanyl domestically. It's really, I think, important for us to have this holistic approach and to really focus on a robust law enforcement response to reduce the availability of heroin and fentanyl. You know, we have to really look at how we work with our Customs and Border Protection folks to increase the detection of both heroin and fentanyl. And I think, you know, to Mr. Milione's point, we have to look at our international work with China that often produces these precursor chemicals as it relates to particularly fentanyl production. We were actually just pleased that China just moved to schedule over 130 new substances, including one of the precursors from acetylfentanyl. So, it really is important for us to work with our international partners, particularly China, Mexico, and working with our domestic law enforcement folks.
Thank you. I yield back.
Back to the gentleman from Pennsylvania, Mr. Cartwright.
Thank you, Acting Chair Micah, and thank you to all the witnesses for coming today. I've listened to all of your testimony, and it's well taken. I come from Pennsylvania. In Pennsylvania, hospitalizations for overdoses due to pain medication increased 225% from 2000 to 2014. Drug overdose deaths in Pennsylvania increased by 12.9% between 2013 and 2014, compared to a 6.5% increase nationally in the same time period. It's a huge problem in Pennsylvania. And Director Botticelli, you mentioned attending a town hall. Earlier this year, I did a town hall in my district in Coaldale in Schuylkill County, Pennsylvania. It's a rural place. Typically, we get between 30 and 40 people out for routine town halls. At this one, we had over 100 people come out, and nobody was smiling. Every family is touched by this crisis, by this epidemic. The question is, what can be done to combat it? In Pennsylvania, there is a company, Iroko Pharmaceuticals, that is right now using nanotechnology and is following the FDA directive to use the lowest effective dose of NSAIDs for chronic pain. Iroko is an African-American-owned company which is growing by the month, providing not only jobs in Pennsylvania, but also a logical solution to our national opioid epidemic. I also believe there are legislative solutions to help address the issue, like H.R. 953, the Comprehensive Addiction and Recovery Act. And now this was introduced in the House by Representative Sensenbrenner of Wisconsin. In the Senate, the same bill was introduced by Senator Whitehouse of Rhode Island. That bill passed the Senate, and in the House, I am a co-sponsor of 953. It is a bill that would adjust existing authorizations and programs to provide a series of resources and incentives to help healthcare providers, law enforcement officials, states and local governments expand drug treatment, prevention, and recovery efforts, and throw funding toward those efforts. I wish to urge Republican leadership to move H.R. 953 to the House floor for a vote. It is a concrete step we can take in the right direction. Now, my colleague, Mr. Lynch, talked about New England, and the New England area has been referred to as, quote, the cradle of the heroin epidemic by the New York Times. And I see you nodding your head, Mr. Milioni. You're aware of that, I take it.
Yes, sir, I am.
According to the DEA's 2015 National Heroin Threat Assessment Summary, 63.4% of New England law enforcement agencies reported heroin as their greatest drug threat. And just last week, Governor Charlie Barker signed legislation making Massachusetts the first state to pass a statewide cap on first-time opioid prescriptions. My question is, with the rising number of opioid deaths, what steps has DEA taken to collaborate with the state and local law enforcement agencies to reduce opioid overdoses and deaths?
Congressman, thank you for the question. Under the leadership of our special agent in charge up there, Mike Ferguson, they've got a great relationship with the U.S. Attorney's offices, and they've brought together all the different elements, state, federal, local, working with the health community to identify where the hot spots are and then to do the community outreach piece, but also do the enforcement on the groups that are trafficking in those substances.
Okay. And Director Botticelli, how is the federal government working to encourage and support innovative ideas by the states to combat the opioid epidemic?
I think there are a number of ways that we are doing that. One, looking at funding opportunities to provide states, I think, with the opportunities to really create innovative strategies. You know, one of the things that our office does is really look at how do we promote some of these innovative things that are happening at the state levels. So whether that's law enforcement that are working to get people into treatment or things like the 24/7 triage programs. So part of what the federal government's response is ensuring that states and locals have the resources they need to continue to implement programs that address these issues. You know, Secretary Tennis in Pennsylvania, I think, has really demonstrated some really strong leadership in terms of the work that's happening here. So I talk with the Secretary just about every day in terms of looking at what more the federal government can continue to do. But I think the largest function that we have is making sure that states and locals get the resources they need to continue to develop and show leadership on this issue.
Well, amen to that, and I yield back, Mr. Chair.
Recognize Mr. Heiss from Georgia.
Thank you, Mr. Chairman. The CDC in Georgia has reported that Georgia alone has seen a 10% increase in overdose deaths. I'm sure you've seen that in the last couple of years. And to me, this is especially alarming just by the fact that high school students are using painkiller medication at alarming rates, which makes them 40 times more vulnerable to use heroin. The DEA said that heroin is currently available in larger quantities, that it's used by a larger number of people, and it's causing an increasing number of overdose deaths. Is that correct?
Yes, sir.
I want to focus on where this stuff is coming from. So, Mr. Milioni, let me start with you. From your testimony regarding the DEA's new 360 strategy, which you referred to a little while ago, it sounds to me like the DEA is going to focus less on the Mexico-based organizations that are trafficking heroin and focusing more on the street gangs that are distributing heroin. Is that a correct assessment?
Congressman, it's not. It's more nuanced than that. We are never going to go away from our core mission of working up the chain to the cartel leaders in Mexico. So the 360 focuses on the link point that bridges the violent distribution cells domestically that are affecting the communities, and also the cartels that are flooding the country with the heroin. So it absolutely is not one or the other. It's a comprehensive approach.
So is there a greater emphasis, though, on the distribution side of things now?
I wouldn't say that there's necessarily a greater emphasis. It's a shift of focus so that we can do everything we can to get the violent distribution cells under control and give the communities back their communities.
Is it fair to say, from your assessment, that our interdiction efforts with the cartels have failed, or at least not been as successful as we had hoped?
Congressman, I wouldn't characterize it as a failure. Interdiction is one part of it, but what we're focused on at the DEA are going after the actual individuals that are selling the powder, that are pushing it, the infrastructure, the corrupting influence, the money. Those are the things we're focused on. Interdiction is one piece of that.
All right. Sounds to me like you were just then saying that the emphasis is going to be on the distribution side of things.
No, I don't believe I said that it was going to be just on the distribution. It was going to be on...
I didn't say just, but the emphasis.
There is going to be an emphasis on the distribution as also on the supply side.
Okay, you mentioned a while ago, and I just shake my head with all of this because we've been in this war on drugs forever, and it's getting worse. We're not making any headway on this. And you mentioned just a while ago that we have a great relationship with the Mexican government, and that that relationship. The reality is, heroin's coming across the border more now than it ever has. What good is a great relationship if we're not addressing the problem? At some point, this thing is getting worse and worse and worse, and we're throwing more and more money to it all the time. It frankly doesn't appear to me as though anything is happening to stop the problem that would go to the point of what you said a while ago, that we're addressing this aggressively.
Congressman, as somebody who served for 20 years and seen the sacrifices that the brave men and women of the DEA do every day in dangerous situations in the country and also in the foreign arena, we're doing everything we can to deal with a very, very difficult and complicated problem. We're working to reduce demand, but we also have to go after the organizations that are flooding our country. So the war on drugs is not necessarily a phrase that we would use. We do criminal investigations into highly dangerous, sophisticated cartels operating foreign.
Well, I take my hat off to those agents who are out there in the field, and I'm not in any way belittling them. But for us to come in here and somehow try to give a picture that we're aggressively dealing with the problem when in reality it's getting worse and worse is putting forth a false image.
I'd have to disagree with you. I'd have to disagree that it's a false image.
Well, you can disagree all you want. The fact is the problem's getting worse. You yourself have admitted that.
Congressman, I don't disagree that it's a difficult problem and that there are parts of it that are getting worse. But I'm not painting a picture that is inaccurate when I say that we're aggressively we're doing everything that we can at tremendous sacrifice.
So how many criminals have been arrested and prosecuted under DEA's Rolling Thunder program?
I can't give you the number of arrests. I can tell you that there's 448 investigations in 125 cities around the country.
But you don't know how many arrests?
I'd have to get back to you with any.
Please get back with me on this.
I'd have to get back to you with any specific statistics.
Okay, Mr. Chairman, thank you. I see my time has expired.
I thank the gentleman. The gentleman from California, Mr. DeSalegna, you're recognized.
Thank you, Mr. Chairman. Well, first of all, I appreciate the panel. I think all of us have stories about constituents who've been affected by this and the frustration, I think, some of my colleagues at our inability as a country to deal with the drug problem, no matter what we've tried. I'd like to ask a couple questions on the opioid side. I have one constituent who came to me and made me aware of her personal situation where her son was going to school at the University of Arizona and drove to Los Angeles with some other students to actually go to a doctor in Los Angeles and then overdosed. This doctor was just recently convicted, multiple convictions in Los Angeles. I have another constituent who went out to walk to a Baskin-Robbins on a Sunday afternoon, and one of his two kids was killed right in front of him when a woman who had been abusing opiates and drinking came across. So all of us have those stories, unfortunately. One of the things we were able to do in California, and Mr. Liu and I were part of this in the legislature, was update our prescription monitoring system. So my question's really around electronic health records, where I would talk to doctors and they'd say, well, electronic health records are right around the corner. Doctor shopping will be a thing of the past. We worked with the Attorney General in California, and that process is in effect now, but we're just waiting to see how effective that is. So, Mr. Botticelli, maybe you could tell us, and one of the frustrating things, of course, is when you have this patchwork of different states doing different things, it seems to me that it would be fairly efficient for the federal government to provide the infrastructure for a nationwide electronic monitoring system so that the Department of Justice in all 50 states and the Federal Department of Justice would have red flags so that they would see if a doctor, like the doctor in Los Angeles, is abusing his or her privileges, or if a client is doctor shopping. Mr. Botticelli.
So prescription drug monitoring programs have been part of our main emphasis since the beginning of this epidemic, and I think to your point, we're seeing tremendous amount of success. You know, we actually looked at when we started, we had only 20 states that had effective prescription drug monitoring programs, and now we have 49 states to do that. We actually thought it was more prudent because we had so many states that already had an existing program to really look at state levels. But to your point, I think what we're trying to focus on next is interstate data sharing so that states can talk to one another, and interoperability with electronic health records, right? Because that's the next phase of, you know, we want to be responsive to physicians in terms of the burden of workload and look at how do we get timely information to them by supporting that. So we've been working with HHS and others. This is an important priority for governors as well, so we've been talking to the National Governors Association in terms of what states can do. But this has really been an effective, one of the more effective tools that we've seen. But we also need physicians to use them.
Right.
And so part of this is, you know, again, I think we're very interested in states that have passed not only mandatory education, but like Massachusetts just did, checking the prescription drug monitoring program, not only at first dispensing, but at every dispensing.
So it's mandatory.
So they're only as good as when people use them.
And Ms. Enomoto, maybe you could talk to this. In California, we have a lot of, Northern California, a lot of Kaiser clients. So there you have a closed system where there's still a problem. And so there's a financial aspect to this. For them, if they were able to use electronic records, both for the cost and efficient use of their system, but also to protect clients from being either overprescribed or clients taking advantage of the system. How far away are we from having a real strong electronic monitoring system that can do both?
You know, I think we're seeing in some states already great progress. So in 2012, SAMHSA had the opportunity to issue grants for the enhancement of prescription drug monitoring programs that focused on both the interoperability with EHR as well as interstate interoperability. And in those grants, during the period of the grant, we got 6 out of the 9 states that were able to achieve that level of interoperability. And then post the grant, we have 2 more states who are now online with their MOUs so that they should be able to start exchanging information with their EHRs very soon. And so, you know, out of a relatively small investment, partnering with CDC, partnering with the Office of the National Coordinator and ONDCP, we were able to get 8 out of 9 states to achieve that level of interoperability.
And lastly, a statistic that always comes to mind, that the U.S. has about 5% of the world's population, but we use over 80% of the opiates
How much of this is the criminal aspect of it? Mr. Botticelli?
I would actually say very little. You know, again, I think this has been a concerted effort by the pharmaceutical company to treat, you know, to look at falsely promoting those medications. You know, in 2013, we prescribed enough prescription pain medication to give every adult American a bottle of pain pills. And I think that's why, you know, the CDC guidelines become so important of looking at not having opioid therapy as a first-line defense for chronic pain, really supporting when you do start with opioids for some people who do need them, you know, starting with the lowest dosage and the smallest possible amount, because I really do believe that, you know, we've made progress in many areas, and I don't believe that we've made enough progress in really implementing safe opioid prescribing behavior.
Thank you. Thank you, Mr. Chairman.
Thank you. Let me recognize now Mr. Carter from Georgia.
Thank you, Mr. Chairman, and thank all of you for being here. I've been kind of in and out. I apologize. I had 3 committee meetings at one time and at the same time. But I want to associate myself, first of all, with all the comments that have been made about marijuana being a gateway drug and leading to drug abuse. And I could not feel more adamantly about that. So I just want to make sure everyone understands that. For those of you who don't know, I'm a pharmacist, not practicing anymore. The only pharmacist in Congress. I have over 35 years of experience and a lot of experience with opioids as a dispenser. I'm very blessed that I've never taken any drugs and never had that. You know, I'm human, I have weaknesses, but that's not one of them, and I feel very strongly about that. I want to start with you, Mr. Million. You know, this is very uncomfortable, but I will tell you that almost a year ago, a little over a year ago, in fact, in Tampa, a judge ruled against the actions of the DEA when you raided a compounding pharmacy. You destroyed the medication and completely shut down the pharmacy without any real cause. This was West Chase Pharmacy in Florida. You familiar with that situation?
I'm not.
You're not? Well, you need to be, because let me tell you, this is not a shining example that you want to point toward. This is an example where one of your supervisors that you oversee conducted a raid and at the time had no experience in diversion investigation, hadn't read the DEA handbook, yet raided a compounding pharmacy with tactical gear and guns, shut down the business, seized hundreds of thousands of dollars of medicine, and improperly stored them, therefore rendering them useless, all because the DEA misinterpreted and failed to follow their own laws. This is, as the judge said, preposterous, and this is not to be accepted. Now, look, I support the DEA. I don't like anybody in health care who is not practicing by the best of standards. We've got bad pharmacies out there. We got bad pharmacists. We got bad doctors, Dr. Nguyen. There are bad doctors out there. You can't paint with a broad brush. There are bad actors in every profession, but this kind of action, this kind is totally unacceptable, Mr. Long, especially when you have someone coming to your pharmacy bearing guns. That's unacceptable. So I hope you'll look at that. It's West Chase Pharmacy. I hope you'll research that and understand that. I want to ask you, Dr. Nguyen especially, you know, we've talked about opioids being used as the entry-level drug for pain control. One of the problems that I see here, and Mr. Botticelli, you and I have worked together before. You know, I sponsored the legislation in the Georgia State Senate to set up the PDMP for the Georgia. But one of the problems I see is with the FDA taking a lot of the products off of the market. Now, specifically, I want to talk about propoxyphene. You know, propoxyphene nacillate was on the market for years and years. I can't imagine how much I dispensed in my career. But I would tell you, when they took it off, what did it do? It led people on the opioids. That's the only choice the doctors had. What do you do now? You've got ibuprofen and acetaminophen. That's where you want to start. Well, let me tell you, as a practicing pharmacist, I can tell you, you try to get a patient to take something that's available without a prescription, you're not going to be able to convince them that it's going to work. You got to have a prescription for it. That's just the way it is. No, it's not right, but I will try as hard as I can, and I can't convince them of that. But I would tell you, and just like the propoxyphene, don't give me that white one. Only the pink one works. That's the only one that works. That's what you're dealing with. But one of the problems, I think, has been the FDA taking, and I know that propoxyphene had its problems. I'm not trying to question that. But what I'm trying to point out is that we need some more entry-level drugs, something in between the opioids and those, and ibuprofen and acetaminophen. That would be better. The CDC guidelines that have come out for the prescribing guidelines for doctors, I think that's very, very helpful. It needs to be enforced more. It needs to have some kind of teeth in it. And I'm running out of time here because I want to get into so many things. Another problem is mail-order pharmacies sending these gigantic containers of opioids to the doorsteps of people, leaving them on the doorsteps for them to be, and who knows what's going to happen to them. You know, you get a 90-day supply. I have people bring into the drugstores that my wife now owns. They bring into those drugstores all the time giant containers of opioids. That needs to be suppressed, Mr. Milian. DEA needs to do something about that. That is ridiculous and something that we need to address as well. The last thing I want to talk about is 21st century cures and the lock-in provision, because that is something, listen, I'm a big proponent of 21st century cures. I think it's some of the best legislation that we've passed here since I've been in Congress, and I support it, and I voted for it. However, that lock-in provision is very dangerous, and I think it needs to be looked at. You have a relationship between pharmacies and patients, between doctors and patients. When you get into a lock-in provision, it's going to be very, very difficult, because you need pharmacists. You need pharmacists to participate in this and help us to curb this problem, because it is, let me tell you, I've seen it ruin families, I've seen it ruin lives, I've seen it ruin careers, and it is worse than can even be imagined at this point. Mr. Chairman, I know I've gone over, and I apologize. Thank you.
Thank you. Gentleman from Virginia, Mr. Conley.
Thank you, Mr. Chairman. And I will say, Mr. Mike and I had a series of hearings in the previous Congress on U.S. drug policy, and that included marijuana. And it forced me to re-examine some things I thought I knew or believed about our drug policy with respect to marijuana. But what is disturbing to me is if there's a gateway drug to heroin, it's opiate prescription drug addiction, far more than marijuana. And that's why this hearing is so timely. It's affecting every community we represent here in this body. It's not a rural phenomenon or an urban phenomenon or a suburban phenomenon. And you know, well, let me ask you, Mr. Botticelli, how did we get to this point? I mean, I don't want any doctor to leave a patient in pain. Serious pain, you know, is a terrible affliction. And first, you do no harm. But how do we draw that line between pain management and just an unbelievable avalanche of prescriptions for opioids that has now led to an epidemic of addiction in America, with the best, presumably the best of intention originally?
I agree, and you know, I think when you look at the roots of this epidemic and one of the significant drivers, yes, there are other issues going on. It's really about the overprescribing of these very addictive pain medication that we have. And
but why? How did we get there? Doctors aren't stupid people.
Well, I think that doctors were given a significant amount of misinformation from pharmaceutical companies and even from the medical profession themselves, that these were not addictive medications, right? So that was really the start of this, that there was, despite scant scientific evidence, there was this full court press to basically educate physicians and saying that these medications were not very addictive. And at the same time, we had, which I think was a very noble and should be a noble goal, that we have to do a better job at pain treatment in the United States, that there are a lot of people who have significant pain and we need it. So I think you had this confluence in terms of really a full court press to treat pain, right? The VA even talked about pain as the fifth vital sign, and little education on the part of these prescribers about how addictive these substances were, about how to identify people. So physicians in the United States get very little training on appropriate pain prescribing. I think there was a GAO study that showed veterinarians actually get more training on pain prescribing, and physicians get little to no training on substance use issues. So I think it was this kind of mixture of a whole set of factors that really drove up addiction and overdose in the United States. And I think of late, now we have that compounded by heroin and fentanyl availability.
Dr. Nguyen, what is effective treatment, and how, I mean, what's the system for recognizing, hey, somebody has a problem and we need to get them treatment? What's efficacious treatment in trying to turn this around early before it moves on to, say, heroin or something worse?
It's often said that medicine is an art and not completely a science because even something like pain is subjective. What's 10 out of 10 pain to you is not the same as for somebody else. And so that's why doctors do need discretion about how to treat each individual patient based on their symptoms and who they are. Also recognizing that it's not just about medications. We also have to do physical therapy and counseling and education that sometimes pain is okay. We don't have to treat everything with a pill. And so, but we very much agree with increase in the use of PDMPs, recognizing though that some PDMPs are very cumbersome to use. And if I'm seeing 40 patients in 8 hours, I can't be spending an hour of that time figuring out how to get into every patient's PDMP.
Got it, but we're running out of time. So what's efficacious treatment? What do you recommend in the Baltimore Health Department?
We recommend, first of all, judicious use of pain medication so that we're not
I
using
get that. I'm
opioids
talking
as
about
first.
treatment. We got a problem. What's the treatment? What's efficacious? What have we learned? Because, look, we're policymakers up here. We want to solve a problem. We get that part. But if we've gone to the point where we've got an addictive problem, but we're trying to prevent that person from going on to the heroin part, what works? What in your experience, what works by way of intervention?
One thing, recognizing that addiction is a disease, and therefore we have to get people into addiction treatment, which is medication-assisted treatment, psychosocial counseling, and wraparound services. We know that the World Health Organization shows for $1 invested in treatment, that saves $12 for society, and that's something we should invest in.
Thank you very much, and thank you, Mr. Chairman. And thank you for the hearings you and I held.
That's right.
They were quite informative.
Probably the only ones in Congress, and we got criticized for them, but we went through government operations. He was my ranking member, and then years ago with the ranking member here. So
thank you again, and thank you to the panel.
Gentleman from Wisconsin, Mr. Grothman.
3 seconds to Buddy Carter.
I thank the gentleman for yielding. I would be remiss if I did not mention next week in Atlanta, of course, we're having the National Prescription Drug Abuse and Heroin Summit. Representative Howard from Kentucky, who has been a champion for this, is the co-chair of that. I hope that you will be there. I hope that my colleagues will be there. This is an opportunity to learn more about prescription drug abuse. It is a great, great summit, and I encourage everyone to attend. Thank you. I thank the gentleman for yielding.
Anytime. Okay, now I have a question. One of the things that bothers me is the legal prescription of opiates. I've had 2 minor health things in my life in the last 2 years that I had earlier in my life. Both times the medical professionals were willing to give out opiates, like I believe a month's worth of opiates, for something that had no business under any circumstances prescribing opiates, and they wouldn't have 5 years ago. I guess I'll start with Mr. Botticelli, but anybody else can chime in here. What can we do to stop in these basic things? I'd say what they were, but I don't want to embarrass the medical professionals because I have a feeling they were par for the course. I mean, one of the things that throw out my mind, say, we're not going to reimburse for Medicaid, we're not going to reimburse for Medicare, we're not going to reimburse if you're, anything else the federal government is kicking in for these sort of problems, no matter how much pain you claim you had, because people never used to have them. Or we could perhaps say, even for CMS, say we're just not going to reimburse across the board. And if we are ever going to reimburse, it's for like 3 days, none of this month subscription stuff. Is that something that could be done? And I don't think we can give the medical professionals a lot of wiggle room here, because they've shown in the past they abuse that wiggle room.
I think there are a number of things that we can be doing. I think, one, you're right, I think there's opportunities to work with not only CMS, but private insurance as well with that. I'm very familiar
Why don't we do it?
CMS actually sent out a letter to state Medicaid directors this summer to really look at putting in place prescribing protocols around that. I also think that we really need to continue to focus on mandatory prescriber education. I think, I'm not a big fan of government mandates around that, but I do think that, again, we really need to educate the medical profession about safe and effective opioid prescribing.
All you need, I hate to cut you off, all you need is a little common sense. I mean, if we have that many people in the medical field that lacking in common sense, we have a bigger problem than lack of education.
I don't think it's a matter of common sense. I think it was a matter of a medical profession, very well-meaning to the largest extent, who were given misinformation on the lack of addictive properties of these drugs. And it was really a full court press to more appropriately treat pain with a prescribing community that gets little to no training on appropriate pain prescribing.
Well, 90% of the people in an average Wisconsin fish fry know this is all screwed up. I can't believe that the medical professionals need training on this, but okay, if you say they need training. Now I want to come around to the penalty thing on Mr. Malone. Maybe I got here late, didn't hear your name. It seems to me that the penalties for people who sell heroin is not as high as it should be, or they are not going to prison as long as possible. Now, one of the problems I have is a lot of this is local stuff. It's not a federal issue. But I assume we do arrest people, and the federal government arrests people who possess heroin, or possess heroin at least enough that you can assume that they are dealing in that drug. Do we arrest people for that? And if we do, what is the recommended sentence?
Congressman, at the DEA and the federal level and in our task forces, we're not focused at all on users or simple possession necessarily.
I'm not saying simple possession. If you get somebody with enough heroin, which isn't very much, that you know it can't be for personal consumption, you know they're going to be selling for somebody, what do you do with that person?
It's not I can't really give it a quick answer like that. It depends on the investigation, and obviously in conjunction with the federal prosecutors we work with or the state prosecutors, they look at the conduct, and then ultimately a judge decides what that sentence is going to be based upon the guidance that the judge gets. So that's the clearest answer I can give you. It's not a very clear answer.
It's a very muddy answer, yeah.
Yeah, but it's the world we live in.
Okay, we'll give you one more quick question, then I'll hang around here to see whether the chairman eventually can call on me again if I wait long enough. What do they do in other countries in this? I toured another country like 10 years ago, and I asked about a drug problem. And they told me the criminal penalty for these severe drugs was shockingly high. I won't say what it was, because it might have been wrong. Shockingly high. What do they do in other countries to make sure they don't have this big opiate abuse? Say in Southeast Asia, where in some of these countries they don't. What type of penalties do they hand out?
So it's interesting that you say that. I actually just returned from, there's a UN group of my colleagues from around the world in terms of looking at kind of global approach to drug policy. And I think that there is an emerging consensus with the vast majority of countries that we need to continue to focus on an enhanced public health response. That while law enforcement plays a key role for some of our major traffickers, that we need to look at and continue to explore alternatives to incarceration. So I think that there is a kind of consensus among countries.
I don't mean to cut you off. I'm well past my time, and because I'm past my time, I'd like it if you'd answer my question. Okay, I know that there are a lot of people out there who like this public health response. Okay, I am under the impression, however, we put people in prison for a reason. Okay, other countries have very large penalties and much less of an opiate problem. Could you tell me what their penalties are?
Well, I think they probably have less of an opiate problem because in many parts of the world, most people actually don't have access to medications at all. So it's not a function that they have criminal penalties.
No, you're wrong, but you can just tell me what they are, because these are countries that are fairly advanced and they don't have an opiate problem, and part of it is the penalties are pretty dramatic. Do you know what these penalties are, say, in places in Southeast Asia?
I don't, but I can tell you that Southeast Asia considers labor camps part of their treatment regimen. So I wouldn't necessarily equate kind of drug policy around there as it relates to their drug problem.
Thank you. I think Singapore, they also execute them. Mr. Liu from California, you recognize.
Thank you, Mr. Chairman. Mr. Botticelli, thank you for your public service. I have a few questions for you. Let me begin by saying that the current heroin and opiate epidemic has some similarities to the crack epidemic of the 1980s. Unfortunately, our response back then was to increase prison sentences. I'm pleased to see we're taking a different approach this time, and America is finally starting to realize that drug addiction is primarily a disease. One of the most noticeable differences between the crack epidemic and the opioid epidemic is that the crack epidemic mostly affected poor communities of color, but the face of the opioid epidemic is very different. According to a study published in Journal of American Medical Association, nearly 90% of the people who tried heroin for the first time in the past decade are white. Does that statistic sound largely correct to you, sir?
It does.
Okay. I have an article here in the New York Times titled, "In Heroin Crisis, White Families Seek Gentler War on Drugs." In that article, you quoted as saying, because the demographic of people affected are more white, more middle class, these are parents who are empowered. They know how to call a legislator, they know how to get angry with their insurance company, they know how to advocate. They have been so instrumental in changing the conversation. And you said that, correct?
Mm-hmm. Correct.
So I believe it's important that we need to address these issues among the white middle class, but I want to make sure also that our resources are directed across the country regardless of socioeconomic or race status. And my question to you is, how do we ensure that federal resources are applied fairly and match the unique issues facing individual communities?
So, thank you for your comment. It's a really important issue to me and to you and Congressman Cummings. I've been doing this work for the better part of my life, and I'm glad that in this country we're finally at a point where we've acknowledged the disproportionate impact on people of color and poor folk in terms of this issue. And I'm glad we're at a different place. I'm glad that we have now a huge political movement that's happening with people around the country to call for a different response. I completely agree. I think that we have to make sure that the policies that were implemented, that the programs that were implemented are targeted at those communities that have the most pressing need. And that when we talk about things like criminal justice reform, we're talking about criminal justice reform for everybody, regardless of color, as it relates to this, that our human response to this epidemic needs to be a human response for everybody, and not just for the 90% of white people who are affected by this issue. And I'm glad we've learned a lot over the past 40 years in response to failed drug policies in the past. I'm glad we are at the place where we're finally acknowledging that this is a disease, and that we can't make our jails and prisons our de facto treatment programs for anybody. So, I feel a tremendous responsibility in terms of making sure that we use this moment in time where there's broad acknowledgement of the fact that this is a disease and that we can't arrest and incarcerate, that we implement those policies and programs for everybody.
Thank you for that answer. And Mr. Chairman, I'd like to enter for the record the New York Times article, "In Heroin Crisis, White Families Seek Gentler War on Drugs."
Without objection, so ordered. And
now, there's been anecdotal stories today that marijuana is a gateway drug. Are you familiar with the article in Time magazine that says marijuana is a gateway drug, the myth that will not die? Have you read that article?
I don't know if I've read that precisely.
Sure. So let me quote from it. It says that scientists long ago abandoned the idea that marijuana causes users to try other drugs. As far back as 1999, in a report commissioned by Congress to look at the possible dangers of medical marijuana, the Institute of Medicine of the National Academy of Sciences wrote, "There is no conclusive evidence that the drug effects of marijuana are causally linked to the subsequent abuse of other illicit drugs." Now, it is true there is a correlation, and this article in the study explains that underage drinking alcohol also has a correlation, that those actually use typically precedes marijuana, and that marijuana is not the most common, and is rarely the first gateway to illicit drug use. And then this article goes on to say, well, why might there be a correlation? And one simple reason is that people who are extremely interested in altering their consciousness are likely to want to try more than one way of doing it. So if you're a true music fan, you probably won't stick to listening to just one band. That doesn't make lullabies a gateway to the Grateful Dead. It means that people really like music, probably like many different songs and groups. So isn't it correct that there is no scientific evidence that marijuana is a causal link to illicit drug use?
I think that the evidence is pretty clear that early use of alcohol, tobacco, and marijuana, often used together, significantly increases the probability that someone will develop a more significant addictive disorder later in their life. And I think that's the younger people use, the more that those chances grow. And I also think, you know, the music analogy is kind of inaccurate in this situation, because early substance use actually affects brain development, not just affects people's taste, and it actually affects people's brain development and predisposes people for more significant vulnerabilities later in their life.
Thank you. My time is up. I'll send you an article on that issue also. And Mr. Chairman, if I could enter into the record the Time Magazine article that says marijuana as a gateway drug, the myth that will not die.
Without objection, so ordered. The gentlelady from New Mexico, Ms. Luan Grisham.
Thank you, Mr. Chairman. I have no doubt that we will continue in Congress and localities and cities and states will continue the debate about gateway drugs. Certainly, I participated in many of those discussions about alcohol, which is really the foundation in terms of creating an environment where you put yourself more at risk, particularly adolescents and adolescent drinking. And I come from a state, unfortunately, that has some of the highest drug abuse rates and the highest overdose rates in the country. And Mr. Botticelli, I appreciate very much you raising the issue in your testimony and talking about there is now a very direct and specific correlation between the number of prescriptions that have gone up and the number of prescription drug issues, which we're trying to deal with today. And while I would hope that Congress undertakes an effort when we're combating the opioid problem, that we look at drug issues in general, drug policy in general, and certainly continue to debate and work on criminal justice reform so that we're focusing on both prevention and effective treatment, which is really the way to get at it. I also want to say I appreciate the panel and members' questions. You know, I'm in a state that just passed legislation that would make naloxone available to far more than just the medical providers and prescribers, that we want it to be in the jails, we want first responders, and first responders was debated to include family members in close proximity so that we can prevent overdose deaths. And in a state that's got a Republican House and a Democratic Senate, there was great bipartisan effort to recognize if we can prevent an overdose death, let's do that. But now let's not minimize everything else. So finally, potentially a question, and maybe either Director or Dr. Wen, this is a very complex set of problems, and that doesn't mean that we should walk away from it, and I could probably get into a debate with you right here about good faith dispensing and how that can be a benefit and how it'll also limit access. And one of the realities about overprescribing isn't just that the sellers and manufacturers of these drugs have done such a great job. Now it's cheap, and so insurance companies are more than happy to make sure that that's right there. But if you can't get back to your physician, you are in the hospital or in the ER, and you waited 27 hours to be seen, they need to make sure that whatever prescription they're giving you is going to tide you over. The issue is that you've got lots of these patients who have other family members who then have access to the excess medication. And I'm struck by the number of now large pharmacies that are thinking about making sure that they've got kiosks and opportunities for you to get rid of those drugs safely and get them out of the hands potentially of guests and kids and families and grandkids, which is clearly part of the epidemic here. Given all of these complexities, I really want to talk about the behavioral health correlation too, where we aren't treating, there really isn't mental health parity, and in my state we now have no behavioral health infrastructure, which I should admit to you that I think is partially the fault of this administration. Through CMS and HHS. So there's zero treatment available. We have the highest heroin, some of the highest heroin overdose rates, and in Rio County, it's been the highest. 1 in 500 is going to die of a heroin overdose. It's huge, and it's not new. It's decades old. What are we doing to really create policy that recognizing that behavioral health, that dual diagnose and self-medicating is really also part of this larger problem here.
I'll start, and then I'm sure the other folks on the panel can do that. So, I think there are a number of things from a large policy perspective that has happened. One is the Affordable Care Act. And one of the dramatic things why 2 in 10 people get...
I'm going to really just caution you. The Affordable Care Act is the reason this administration has said that they was okay to cancel 100% of all the behavioral health providers in my state. So in that example, it doesn't quite work, although I'm a fan of general access. Make no mistake, but you should know that about New Mexico.
Well, I will just say that part of the reason that people are not able to access care is the fact that they don't have affordable coverage. We know that from data. The Affordable Care Act says a couple things. One, that mental health and substance use disorder benefits have to be a part of any marketplace plan. That's huge because there's always been a lack of coverage. The second thing that it does, to your point, is basically say to insurance companies, you can't discriminate in the provision.
So how are we enforcing that? Because I would tell you that access is still a giant issue in my state and so many others. So we recognize it in policy, but what are we doing, and there's only 10 seconds left, to actually make sure it's occurring? And given that now Medicaid is largely a managed care environment, we're going to debate fee-for-service and managed care ad nauseum, I'm sure, in further healthcare reform environments. But the reality is, if the insurance companies aren't really making it available, then you really don't have access in spite of coverage, correct?
I agree, and quite honestly, I hear that a lot in my travels around the country. And I think that, one, the federal government can do more work around enforcing parity, but states can play a key role, and state insurance commissioners can play a pivotal role in this. Providers play a key role in making sure that complaints get to state insurance commissioners about this. So we all have a role to play in terms of enforcing parity and ensuring that we are about to finalize Medicaid managed care rules as it relates to parity. So I would agree that we each have a role to play in terms of parity enforcement.
I'm well above my time. Thank you, Mr. Chairman, for your flexibility and patience.
Thank you for staying and participating. The gentleman from South Carolina, Mr. Gowdy.
Thank you, Mr. Chairman. Agent Melioni, am I pronouncing that correctly? Agent, I want to talk to you for a second about drug court, but before we get to drug court, would you agree that there are some who traffic in narcotics who themselves are not users?
I would agree.
So drug court is not going to be much help for us or for them because they're not addicts, they don't use. So let's go with those who are using drugs. I think you would also agree with me that folks who use drug commit robbery and burglaries and domestic violence and a host of crimes that we consider to have an element of violence. Would you agree with that?
Certainly that contributes to an element of violence, yes.
All right. So you have drug dealers who don't use, and then you have drug addicts who are not engaged in Title 21 crimes.
That's correct.
All right. There are different models for drug court. Some are diversion programs where you just divert out of the criminal justice system altogether. Some, you plead guilty and your sentence is drug court. And we had a dickens of a time in South Carolina of getting criminal defense attorneys to plead their clients to drug court, even though it was in the eyes of everyone better for their client who happened to be an addict. It's tougher than probation. So the criminal defense attorneys had no interest in that. So how do we...
Position to answer that question.
Well, before I go to Mr. Botticelli, I want to ask you something that might be in your wheelhouse, and that would be diversion. You have a background in diversion? Mr. Milione, Agent Milione.
Yes, yes, yes.
All right. Back in the old days, the standard was if physicians prescribed drugs outside the course of a medical practice, a professional medical practice, they actually could be prosecuted themselves.
That's correct.
There was a dip, it looked to me, in the number of cases that DEA was pursuing from a diversion standpoint. Was that just an optical illusion, or at some point did DEA decide to interact more with the pharmaceutical companies and less with the physicians who are actually prescribing the medicine?
I need to know if you're speaking about criminal cases. I'm not aware of any dip on criminal or civil cases, but then there's also the administrative actions, potentially revoking a registrant's registration. So I'm not aware, if you're talking about criminal, I'm not aware that there was a dip in any criminal numbers as far as our criminal prosecutions.
Would you check that for me?
Be happy to.
All right, because,
What span were you speaking to?
well, I've been gone since 2010.
Okay.
So I know that we did DEA diversion cases and we prosecuted doctors, and then it just seemed to me that the focus shifted over to pharmaceutical companies.
Yeah, I can tell you from a policy perspective and also from what we're doing, it has never been any conscious shift. We've aggressively gone after where appropriate. Again, it's a small percentage of the overall number of DEA registrants, but I'll certainly look at those numbers and get back to you on that.
All right, I know it's hard to prosecute doctors, but when you're prescribing medicine without even doing an examination, without even so much as checking blood pressure, you're just running a pill mill, I think, with all due respect to my friends on the other side, prison might be the right place for those doctors. Mr. Botticelli, what kind of drug court can you devise where criminal defense attorneys do not advise their clients against their overall better health to opt for probation instead of drug court?
I'm not familiar with that. I'd be happy to work with you.
Have you met any criminal defense attorneys? Are you familiar with them?
No, I am, and actually, there's been huge support across the board as it relates to our drug court. So if they're,
I'm sure it is if it's a diversion court. I'm quite certain that there is huge support for that.
Yeah.
I'm not talking about diversion where you have no record and you actually don't face any consequence. I'm talking about pleading guilty and your punishment is drug court as opposed to probation, with probation being much easier than drug court.
So there are many drug courts that operate under that model, right? So it's very interesting to me, and again, it's gotten wide support among many folks in the criminal justice world. So if there are particular folks that you would like us to work with in terms of doing some more education around drug courts, what they can do, the various models, we work very closely with the National Association of Drug Court Professionals to do levels of training and outreach, so I'd be happy to work with you.
I'm out of time, Mr. Chairman. Could I ask one more question? Let's assume that you plead guilty to armed robbery and your sentence is drug court. How many lapses do you think are appropriate before the actual sentence imposed is carried out?
And I'd have to go back and see what the guidelines look. I would assume that probably gets interpreted different way by different judges in terms of.
I was asking you.
People who are out there. I actually don't know that in terms of if there is specific guidance around.
I'm talking about best practices. I mean, obviously, for the first offense, the first relapse, it doesn't make any sense. But the 100th doesn't make any sense either.
No, I would have to look at the National Association of Drug Court. It does put out best practice guidance, and I don't know explicitly what.
Would you do that for me so we can have an idea?
Absolutely.
What's fair?
But to your point, I think there's an acknowledgement that many people with substance use disorders do relapse, and we need to have a good response in terms of that. You're right. People need to be held accountable for their actions as well, so there's a real balance between kind of recognizing relapse and still holding people accountable. But I'll be happy.
I'll tell you what I'll do then. In honor of you, I will acknowledge that there are relapses. And in partial honor of me, the next time you have a chance to talk to criminal defense attorneys, you tell them that it's overall in their client's best interest to get off of drugs, not to get onto probation, which is much easier to navigate than drug court. In the short term, it might inure to their client's benefit. In the long run, it does not.
Okay. Happy to do that.
Thank you.
To conclude, we'll do a quick round of summary questions. Mr. Cummings?
Yeah, Dr. Wynn, one of the things that is so disturbing to me is there are certain areas in Baltimore where people are getting methadone treatment. And when you see the number of people and whose lives have been destroyed, and we see the masses of them. And I would say to the gentleman from South Carolina, would invite you, Ms. Gowdy, I would invite you at some point just to come with me to Baltimore. And when you see the masses of people who are using, it is painfully painful, I'm telling you. And I agree that there are those who are selling drugs that are not using, I agree with you that there are folks who are going out there and committing a lot of crime. As a matter of fact, probably most of the crime in Baltimore has something to do with drugs in one way or another. So, but there are also a group of people who are truly addicted, and they're dying at 78 a day. That's major stuff. And so I would invite you, I think when you see it like that, because the chairman came with me to Baltimore and saw what I'm talking about. In some kind of way, we got to get to that. And I think there are a lot of different remedies to try to address these things, but I am definitely not one that wants to be soft on people that are going around and selling death. And I've said that many times. But at the same time, we've got a lot of people who truly are addicted. So, Dr. Wynn, where do you, and the chairman from South Carolina made some good points, where do you draw the line and say, okay, I've got these addicts, but these addicts, some of them are committing crimes. I mean, how do you, go ahead. And what do you think of the methadone treatment? Because, a lot of people question whether you're just keeping people continuing to be addicted to a substance. You follow me?
Thank you very much, Congressman Cummings. So the first issue is that we know in Baltimore that there are 20,000 people who use heroin and many more who are addicted to other drugs. And most of the drug arrests that are happening, there are 73,000 arrests that happen in our city every year. The majority of the arrests that happen are for individuals who are only selling drugs to feed their own habit. What they need is not incarceration. What they need is drug treatment. And that's what we have to provide. And we have to make sure that they get treatment while, if they are incarcerated, they have to get treatment in jail as well.
Can you pause there for 1 second? One thing a lot of people don't know about heroin is you can be addicted to heroin for 30 or 40 years. Am I right?
Yes.
And still function. Is that right?
Yes, there are some individuals who are very high functioning, who are in all walks of life, all professions, while they're addicted to a variety of drugs, including alcohol as well. To your point about treatment, I'm a doctor and a scientist, and I have to use the evidence. And evidence shows that medication-assisted treatment, including with methadone, buprenorphine, are the first line. They are the standard of care when it comes to opioid addiction. And we also agree, though, that we need to have increased treatment, including with buprenorphine, which can be given in an office-based setting, so that will also help us to reduce the stigma around addiction. And Congressman Cummings, I want to thank you also for your leadership in Baltimore City. We hope that there will be additional funding directed to our cities of greatest need, areas of greatest need. We are the ones on the front lines. We are the ones who are innovating, and we're the ones who need the most resources rather than have the peanut butter spread evenly across all areas.
Naloxone, the idea that we were getting, I think, a 10-pack for $190 back in 2014, and then they increased it to $400. Is that right? Have you seen any movement? I know that various states and our Attorney General has been trying to work out something where we can get that cost back down. Have you seen any movement in that area?
We have not. We have not in Baltimore City. Last year, we were fortunate to receive a generous donation from a pharmaceutical company to assist us with over 8,000 units of naloxone. But we can't depend forever on the generosity, on the donation from companies. We have to have this medication that's a generic medication that's on the World Health Organization's list of essential medications available to everyone so that we can save lives.
Well, again, I want to thank all of you for being here today. We do have a lot to do. It's a very serious problem, and we're going to have to try to hit it from a lot of angles. And as the Chairman Micah said, years ago, he and I, you were the chairman and Mikey member of a subcommittee called the Drug Subcommittee, and we did a lot of work there, and we're going to have to do even more. And so I thank all of you.
Let's see, Mr. Grossman.
Sure, I'll give you two quick questions. First of all, drunk driving is a big problem in our society. And when we arrest somebody for drunk driving, some people are alcoholics and have an addiction to alcohol, and a lot of people are just irresponsible people, social pressure, whatever, got a drunk driving ticket. I've only met 2 people in my life who have used heroin. They both went into the criminal justice system. Both felt they were not addicted. Percentage-wise, give me a stab at it. Of the people who are arrested with heroin, possession or whatever, what percentage are addicts, do you feel, and which possession are just people who are social pressure or whatever, want to feel good for the day, are using heroin? What percentage do you think need treatment, and which percentage are people who are just like the person who gets a drunk driving because they just were irresponsible? Could a couple of you give me your guess?
Sure. I'll take a stab at it and take a look at it, and if my colleagues, I would assume that the rates of kind of non-addictive heroin use are incredibly low, just because it's a very powerfully addictive drug. And again,
well, each one of you gets, just give me a percentage. Sure. So I don't have a lot of time. What percentage of people who are arrested for heroin or addiction are like the 2 people that I talked to who didn't crave it, didn't need it? One did it for social reasons, and the one he just was going through a depression at a time. Mm-hmm. What percentage are addicted, and what percent are just using it because my buddy was using it at school?
This is totally back. I would say probably 5% of people who are using marijuana have no addiction to it, but that might even be...
heroin?
Heroin use, I'm sorry.
Only 5% are not addicted. Next gentleman.
I can't give you a percentage. That's not how we don't encounter individuals that way based on the work that we do with the DEA, so I can't give you a percentage.
Okay. Ms. Inamoto?
I think what we could give you is data from our National Survey on Drug Use and Health, which just surveys people about how many people have used heroin in the last month or in the last year, and then how many of those people actually meet criteria for disorder. And I would imagine you'd find fairly parallel realities. We don't do screening on arrest. We don't have the time to do diagnostic evaluations on everyone who is arrested for possession, and so we don't have those data available.
So nobody has an opinion? Do you have an opinion?
No, but I'm happy to get you the data that we do have.
Anybody up there have an opinion? Else have an opinion on the percent that are addicted and the percent are just using?
I can give you my perspective as a practicing physician and also experience in Baltimore, which is that the vast majority, we're talking well over 90%, will be individuals who have an addiction. Heroin comes from opium, and it's one of the most addictive substances in the world.
Okay.
I don't have the answer. I can tell you out of the 2,000 people that come through our jail that acknowledge they're using heroin, all of them have an addiction. Now, the reality is they're acknowledging it because they know they're going to go through withdrawals. But, you know, I think that there's some information that we could obtain through some databases dealing with people that have been prescribed opioids and how many of them have become addicted.
Okay,
I don't really think it's...
Yep, I'm out of time. I'll cut you off because I want to ask one more question. And, okay, so maybe the 2 people that I have met who have actually used heroin and got caught, when they say they were not craving it at all, maybe they're an aberration. Okay, next question I have, just one example. If I break my arm, just a simple break, do you think under any circumstances, given that they never prescribed it 15 years ago, under what percentage of time do you think a doctor should prescribe opiates for a broken arm?
A broken arm is extremely painful, and if somebody had come to the ER with a broken arm, I would give them even IV medications including for opioids. So it does make sense that this is a reasonable use for opioids.
I think you're utterly irresponsible, but would anybody else think in all cases for a broken arm, you should be prescribing opiates? For how long? Say amount for over a week. What percent think if you have a broken arm, you should prescribe opiates, give a prescription for at least a week?
I can tell you what the CDC guidelines recommend in those kinds of situations, that, you know, obviously that's a decision that need to be made between the patient and the doctor. There should be a conversation to do it, but the CDC guidelines say the lowest possible dose and the shortest possible duration.
So would you, if you were the doctor, give a prescription for at least a week? You know, politicians are known for not giving straight answers. You guys, but okay, go ahead. Anybody else have a stab at this? Is it responsible to give a prescription for opiates for at least a week if I crack my arm here?
Sir, if I can take a stab at this. Sure. I'm not a doctor. I'm a mother of 4 children. One of my children has had multiple broken bones in sports. One of them had 3 torn ACLs and meniscus tears. So they've all gone through a lot of surgery. Each time they've been given opioids, and each time I would say it was probably for about a week. In all cases, they were warned. I was warned about what to look for in case of addiction. In every case, they were not on opioids for more than 48 hours. We took them off in 48 hours. So I can tell you that as severe as those injuries were, we weaned them off. I had a severely broken bone in both of my arms. I was off of painkillers in 3 days and never on opioids. So I hope that answers your question. I think anything more than that really needs to be carefully looked at.
Are you a mental health professional? Are you a health professional?
Am I? No, I'm a mom of 4 kids. I think I'm
wonder you've
probably
got
a
so
whole
much
lot of
common
things. I
sense.
could be a mental health professional by the time I raise 4 children.
Good. Well, we got one common sense answer out of the 5, and it was the person who's not a mental health professional, or not a health professional. Thank you much.
I thank the gentleman. Mr. Gowdy.
Thank you, Mr. Chairman. I want to thank all of our panelists, and I want to thank my friend from Maryland for his gracious invitation, which I will take him up on. I would love to go see what's happening in Baltimore. I suspect, Mr. Chairman, that it is, at least on a larger scale, similar to what was happening in my own hometown, which is why I started a drug court in 2000. And in addition to that drug court, we started a drug court for expectant mothers who were using controlled substances during the course of their pregnancy, because I do believe getting them off drugs is infinitely preferable to incarceration in nonviolent cases. I would also say this, Mr. Chairman, and to my friend from Maryland, there is no joy like going to a graduation ceremony for those who have concluded drug court successfully. I have had folks that I prosecuted stop me in the grocery store to show me their certificate from their graduation, and they were prouder of that than anything you or I could have ever accomplished in our careers. I would just counsel folks that we're still going to need prisons, so I'd be a little reluctant to close all the prisons as we open up drug courts. Because the gentleman from Maryland is right. I'd say about half the crime we saw for 16 years, drugs and or alcohol were at the root of that. And there was one addict in particular, Mr. Chairman, who took a hammer to the older couple that lived next to him and beat them. They were in bed, asleep in the middle of the night. He broke in to rob them, and he beat them with a hammer where they were unrecognizable as humans. That was the pathologist's description, not mine. And then he raped the female victim post-mortem. He was an addict, but we're going to need to hang on to those prisons, Mr. Chairman, in addition to the drug courts. And I would be happy to go to Maryland with my friend to see the work that they're doing there, and I would invite him down to Spartanburg. Drug court can save people's lives to get them off. I just hope they get off before they do acts of violence against the innocent public, because the addicts sometimes leave a wake of violence and mayhem in the wake of their addiction. With that, I would yield back.
Would gentlemen yield, please, just for 1 second?
Be happy to.
First of all, I want to thank you for agreeing to come to Baltimore. I agree to go to South Carolina. Be happy to. And just one thing, Mr. Chairman, I agree with you. We have very effective drug courts in Maryland. And I know what you're talking about. When one of my first cases was a death penalty case, early in my career, where a young man hammered his grandmother to death, and he was on drugs. So I get it. I get it. I'm just trying to, like I said, I think there are different categories here of folk, and I swear, I just wish we could catch them early, like you said, because I've seen some really bad stuff. So I think the thing is trying to figure out a balance here. And even when you figure out the balance, you're probably going to still find people falling through the cracks. But I guess we have to use our best science and best judgment. But thank you, gentlemen, for your...
Yes, sir.
Well, I thank the members for participating and our witnesses. I just have a couple of final things. It's now 1 o'clock. We started this some 3 hours ago. 15 people in the United States have died from drug overdoses, 3 of them from heroin. Before the day's over, 120 Americans will die, 24 of them from heroin. We've heard different things touted here today. Some people have said, well, we just need to put more money into treatment. Treatment is essential, but treatment is at the end of the line. And you heard a couple of comments from the other side of the aisle today that we need to act before we go home at Easter and put more money into the heroin and drug overdose situation. This is the remarks of Senator Grassley on the floor. In fact, according to the Office of National Drug Control Policy, the Appropriations Act passed in December provided more than $400 million in funding specifically to address the opioid epidemic. This is an increase of $100 million over the previous year. That's 25% increase, okay? None of that money, when he said that just a few months ago, has been spent yet. All of that money is available today. Is that right? Or most of it? Tell me. Most of that money is available today, and you would think we're going out of here and not providing money. 25% increase. I want this in the record, and then let's put in the record, too, the record of how much was asked for, how much was appropriated, how much money was taken from interdiction and law enforcement and put into treatment, okay? These are just the facts. We don't want to deal with the facts, but we're going to put this also in the record so you can see that, again, that there is money there. And I want a report. I want a report, I'm telling you, this week of how much money is spent. And I want that in the record, okay, Mr. Botticelli? And then I want something from you, too, Ms. Director of our Health and Substance Abuse Office, okay? I want to see how much money is pending, and I want it in the record, and I want it in my office, okay, by Friday. Close of business. Because I know the money's there. It hasn't even been distributed. So we're not going to play these games. I want the facts there. And we need to stop this stuff at our border. It's coming in. I just showed my mayor, also I think cited it. It's coming in by the boatload across the borders. I have one question, too. I talked about El Chapo. The biggest drug czar coming across the border like it was some kind of a vacation holiday. I was told, speaking of weapons which are used in most drug offenses, isn't that most of the murders are killed. In Baltimore, they're killing people in drugs. In Orlando, we're killing them. We kill them at the mall. We kill them on our streets, in our great communities, our poor communities. We're killing them. But most of them are gun deaths, and they're related to drug trafficking, aren't they, Mr. Maloney?
Yeah.
Yes, yes, and a lot of those are illegal weapons. Now I'm told, I just got this morning, El Chapo, who is coming back and forth, he also, one of the weapons he had was traced to the Fast and Furious. So it was a weapon that was supplied by the United States government, and the principal drug trafficker who's trafficking across the border like a holiday visit, he had one of the Fast and Furious. Are you aware of that?
I'm aware from the press reports.
Okay, can you confirm that also for the committee?
I wouldn't be in the best position to do that.
Okay.
Yeah, it would be another agency. I'd take it back to the department.
All right, well, I want you to check on it for me and let me know, okay? And I'm very pleased with the people out there, but I met with some of your people, and the prosecutions are not what they should be. You know, you go to Singapore, and they do not have a treatment program. I want to put you out of business, Ms. Wen. All the treatment programs, I want to put them out of business because our kids and our adults should not have to go to treatment. but we're allowing this crap to come into the United States. It's offensive. We're killing tens of thousands, folks. I mean, and anything else, people would be outraged. Where are you? Just say no and saying just say maybe, there are consequences, or just say okay makes a difference to our young people and what's happening. So you can tell, get a little hot, the Italian comes out of me. But I've seen them. I've seen them dying in the streets of Baltimore, and I see them now dying again in my community, and we need to do something about it, and that supply has to be cut off, and then I can put Ms. Wen and others out of business. We won't have to be treating people. We won't have the scourge on our streets. There being no further business before this committee, if the House, this hearing is adjourned. Thank you, witnesses. Get me going.